കേൾക്കാമോ? ഞാൻ പറയുന്നത് കേൾക്കാമോ? മാളു കേൾക്കാമോ? രജനി സർ കേൾക്കാമോ?
എനിക്ക് കേൾക്കാം. കേൾക്കാമോ?
നല്ല ക്ലിയർ ആണ് സാർ, നല്ല ക്ലാരിറ്റി ഉണ്ട്. സാർ വേണമെങ്കിൽ ഒന്ന് ഷെയർ ചെയ്ത് നോക്കാമോ? അതിന്റെ സ്ലൈഡ് ഒന്ന് ഷെയർ ചെയ്യാമോ?
ഷെയർ സ്ക്രീനിൽ പോകണം. അതിൽ പോയിട്ട്
ഞാൻ അങ്ങോട്ട് വരാം.
അതായിരിക്കും നല്ലത്. മാളു കേട്ടൂടാ.
അവരൊരു പി പി ചെയ്തേ 4:30. എങ്ങനെ മനസ്സിലാക്കാം?
യൂട്യൂബ് ലൈവ് പോയിട്ടുണ്ടോ സാറേ? ഹലോ, ബേസിലെ സാറേ. അല്ലെ, യൂട്യൂബിൽ പോയിട്ടുണ്ടോ? യൂട്യൂബിൽ നോക്കാമോ? കാണാവോ? സ്ലൈഡ് കാണാവോ? മാളു സ്ലൈഡ് കാണാമോ? ഇവിടെ നോക്കും. മാളു സ്ലൈഡ് കാണാമോ?
ഹലോ,
ഹലോ.
ബേസിലാണേ. സാറേ യൂട്യൂബിലും പോയിട്ടുണ്ടോ? നോക്കിയേക്കാവോ?
സെഷൻ ഇപ്പൊ നോക്കും. ഇതിന്റെ സ്ലൈഡ് കാണാമോ?
സ്ലൈഡ് കാണാം. എനിക്ക് മാളു മാഡത്തിന്റെ ഓഡിയോ എപ്പോഴാണ് കണക്ട് ആയത്?
ശരി.
സ്ലൈഡ് കാണാം. എനിക്ക് കാണാൻ പറ്റുന്നുണ്ട്.
കേൾക്കാമോ സാർ?
ഇപ്പൊ കേൾക്കാം മാളു, ഇപ്പൊ കേൾക്കാം. മാളു കുറച്ചും കൂടെ ഇതിനെ കുറച്ച് മുമ്പോട്ടാക്കൂ.
ഇത് മതി സാർ.
മതിയോ?
കൂടുതൽ കാണാതിരിക്കാൻ അങ്ങനെ വെച്ചത്.
ഓക്കെ. നല്ല ക്ലാരിറ്റി ഉണ്ട്, കുഴപ്പമില്ല. സാറ് സ്റ്റോപ്പ് ചെയ്തിട്ട് മാളു ഒന്ന് നോക്കാവോ?
അയ്യോ, എന്റെ തലയുടെ മുകളിൽ ഒരു ഹേലോ കാണുന്നു.
അതുകൊണ്ടാണ് ഞാൻ പിന്നെ കുറച്ച് മുമ്പോട്ട് വെക്കാൻ ഇതിന്.
സാർ അത് ലൈറ്റ് ഓഫ് ചെയ്താൽ മതി. ഞാൻ ഈ ലൈറ്റ് അങ്ങ് ഓഫ് ചെയ്യാം. പക്ഷെ അത്
ഇരുണ്ടു.
ലൈറ്റ് ഓഫ് ചെയ്താൽ കാണത്തില്ലായിരിക്കും. മാളു
ഏതെങ്കിലും ഡയറക്ഷൻ മാറ്റി നോക്ക്.
ഇപ്പൊ
ബെറ്റർ. ഞാൻ എന്റെ സ്റ്റോപ്പ് ഷെയർ ചെയ്യണോ?
മാളുവിന്റെ ഒന്ന് നോക്കാം. എല്ലാവരുടെയും ഒന്ന് നോക്കി വെച്ചേക്കാം. ഓക്കെ, മാളു ഒന്ന് ഷെയർ ചെയ്യാമോ?
സാറേ ഷെയർ ചെയ്യോ? സാറിന്റെ
ഞാൻ സ്റ്റോപ്പ് ഷെയർ
ചെയ്തോ? ഓക്കെ. കാണാമോ?
കാണാം. അത് മെയിൻ ഇതിലോട്ട് ഇടാവോ മാളു? മറ്റേ ഇതിപ്പോ ഫുൾ പ്രസന്റേഷൻ മോഡിലോട്ട്
സ്ലൈഡ് ഷോയിലോട്ടോ?
സ്ലൈഡ് ഷോ ഇടാം.
ഇതിന്റെ സൈഡില് നമ്മുടെ ഇതും കൂടെ വരുന്ന എങ്ങനെയാ?
ഞാൻ അങ്ങോട്ട് വരാം.
മാളുവിന്റെ സ്ലൈഡ് ഷോ ആയില്ല, ഇപ്പോഴും മറ്റേത് കിടക്കും.
ഞാൻ മാറ്റി സാറേ, മാറ്റി.
ഓക്കെ.
മനസ്സിലായി എനിക്ക്. ഓക്കെ.
ക്ലിയർ ആയില്ലേ?
അല്ല ഇത് ശരിയായി. ഇനി നമ്മൾ സ്ലൈഡ് ഷോ
സൈഡ്
ഇട്ടിട്ട് അല്ലല്ല അതല്ല, മറ്റേ ഇതിന്റെ സൈഡിൽ നമ്മുടെ മറ്റേത് കൂടെ കാണുന്ന എങ്ങനെയാ? സൂമിന്റെ
നോക്കിക്കേ, ഹൈഡ് ചെയ്ത് വെച്ചേക്കാം. ഇവിടെ ക്ലിക്ക് ചെയ്തേ. ഇത് ആപ്പിളാണോ? അല്ലല്ലോ.
അല്ല,
മെയിലുണ്ടല്ലോ. സ്റ്റോപ്പ് ഷെയർ യുവർ സ്ക്രീൻ ഷെയർ ഇവിടെ ഉണ്ടല്ലോ. അതെടുത്ത്
അതല്ല.
ഇവിടെ വ്യൂ ഗാലറി വ്യൂ ഇട്ടത്.
ഹൈഡ്
സെൽഫ് വ്യൂ അല്ല, ഹൈഡ് സെൽഫ് വ്യൂ അല്ല. ഓക്കെ, ഇനി അത് നിർത്തി.
അത് എങ്ങനെ യൂഷ്വലി വരുന്നത് എങ്ങനെയാന്ന് ഞാൻ മറന്നു. ഇങ്ങനെ ഒരു പരിപാടി ഉണ്ട് അതിന്.
ഫുൾ സ്ക്രീൻ ചുമ്മാ നോക്കാൻ വേണ്ട.
അല്ല, പക്ഷെ ഫുൾ സ്ക്രീൻ
ജസ്റ്റ് സ്റ്റോപ്പ് ഇൻകമിംഗ് വീഡിയോ സെറ്റിംഗ്സ്. ഷെയർ ചെയ്യാം. അഡ്വാൻസ് ഷെയറിംഗ് ഓപ്ഷൻ ആണ്, സാധാ ഷെയറിംഗ് ഓപ്ഷൻ മതി.
അതല്ല ഞാനത് എങ്ങനെയാന്ന് നോക്കിയത്. പക്ഷേ സാറ് ഷെയർ ചെയ്തപ്പം സാറിന് വീഡിയോ കാണുന്നുണ്ടായിരുന്നോ?
അതിന്റെ സൈഡിൽ വന്നിട്ടുണ്ടായിരുന്നു.
സാർ അൺമ്യൂട്ട് ചെയ്ത് സാറേ.
കേട്ടൂടെ?
കേക്കാം സാറേ.
ചെയ്തപ്പോ ഇപ്പഴത്തെ സൈഡിലോട്ട് വന്നത്.
ഞാനൊന്ന് സ്റ്റോപ്പ് ഷെയർ ചെയ്തിട്ടുണ്ട്. ഷെയർ അല്ലേ? ഷെയർ ഒരു മിനിറ്റ്. വിൻഡോ അയ്യോ മറ്റേതല്ലോ.
അവിടെ കിടപ്പുണ്ട്, ഇവിടെ കിടപ്പുണ്ട്. വളവ് ഫുൾ ആക്കിക്ക്, എന്നിട്ട് ഫുള്ള് മൊത്തം എടുത്ത് എന്നിട്ട് ഞാൻ പറയാം. ഇപ്പൊ അല്ല, എന്റെ സ്ലൈഡ് ഫുൾ എടുത്തേ, ഫുള്ള് മൊത്തം ആക്കിക്കേ, മൊത്തം ആക്കും, ഫുൾ മൊത്തം ആക്കും. അത് കാണുന്നതാണ്. എന്നിട്ട് ഇവിടെ ഓപ്ഷൻ വരേണ്ടതാണ്. ഒരു മിനിറ്റ്.
അയ്യോ അല്ല,
ആപ്സും ഷെയറിങ് വീഡിയോ. അത് സ്റ്റോപ്പ് ഷെയറിങ് എടുത്തേ, അവിടെ സ്റ്റോപ്പ് ഷെയറിങ് എടുത്തേ. കുഴപ്പമുണ്ടാവില്ല, അത് നോക്കാം. അതായത് നമുക്ക് എന്നുവെച്ചാൽ അതിന്റെ എല്ലാം ഫുൾ ആണെങ്കിൽ കുഴപ്പമില്ലല്ലോ. മാളുവിന്റെ എല്ലാ വീഡിയോ കാണുന്നുണ്ട്. മാളു വീഡിയോ കാണുന്നുണ്ട്. ഒന്നുകൂടെ ഷെയർ ചെയ്തേ. ഭാഗ്യ ജോയിൻ ചെയ്തില്ലേ? ഓക്കെ, കാണാം, ക്ലിയർ ആയിട്ട് കാണാം. വീഡിയോയും കാണുന്നുണ്ട്. സംസാരിക്കാമോ?
എനിക്ക്
അതെന്തോ ഒരു പ്രശ്നമുണ്ട്. പക്ഷെ കുഴപ്പമില്ല. യു ആർ എവറിത്തിങ് ഈസ് യു ആർ ബീയിങ് മാളു സ്ക്രീൻ. HP റിലേറ്റ് പോസിറ്റീവ് ആൻഡ് നെഗറ്റീവ് കാണുന്നുണ്ട്. Then we are also seeing your video.
മാളുവിന്റെ
അവർക്ക് അനൗൺസ് ചെയ്യണം. നമുക്ക് അനൗൺസ് ചെയ്യണമെങ്കിൽ ഇതിനെ പറ്റണം. ഇതില്ലേ മാളുവിന്റെ അത് കാണാൻ
ഞാന് സ്ലൈഡ് ഷെയർ ഇത് ചെയ്യുമ്പോഴത്തേക്കും എന്നെ കാണുന്നത്
ഏതാ വ്യൂവിൽ ഇതെടുത്താ അല്ല, പക്ഷെ ഹൈഡ് സെൽഫി ഇല്ലല്ലോ. ഇല്ല, അത് ഒന്നുകൂടെ ഓൺ ചെയ്തിട്ട് ഓഫ് ചെയ്തേ. ഹൈഡ് സെൽഫി എന്നുള്ളതല്ലേ, അത് ഓൺ ചെയ്തിട്ട് ഓഫ് ചെയ്തേ.
വീഡിയോ വരുന്നുണ്ട്. നമുക്ക് ഇതില്ലല്ലോ, നമുക്കിതില്ല. നമുക്കില്ല. അത്ര സന്തോഷം. ഇത് കഴിഞ്ഞാൽ പ്രിയമ്മയുടെ
അയ്യോ സെൽഫി ഇല്ല.
Everything is coming. Your sound is also coming.
ടെമ്പററി അൺമ്യൂട്ട് ചെയ്യാൻ സ്പേസ് കീ എന്തെങ്കിലും പറയാണ്ട് സ്പേസ് നിൽക്കുന്നു പറഞ്ഞാൽ മതി. അൺമ്യൂട്ട് മ്യൂട്ട് അടിക്കില്ല.
ഇതിപ്പോ എന്റെ സ്ലൈഡാ
സ്റ്റോപ്പ് ചെയ്താ അല്ല
സാധാരണ
ആ കസേര ഭാഗ്യ
share. Okay. Okay. Yeah.
Yes.
വെറുതെ ബേസ് അല്ല ഗൂഗിൾ
അതാ
അപ്പൊ അങ്ങനെയാണെങ്കിൽ ഇത് എഴുതി ചെയ്തോ. ഞങ്ങളിപ്പോ ഒരു സ്ലൈഡ് ഇടാൻ പോവാം.
സ്ലോപ്പ് ഷെയർ.
ഭാഗ്യം അനൗൺസ് ചെയ്താൽ മാത്രം
ഒരു കൊച്ചൊരു ഇൻട്രൊഡക്ഷൻ തുടങ്ങിയിട്ടാണ് തുടങ്ങുന്ന സമയത്ത് സ്ലൈഡ് ഷെയർ തുടങ്ങിയ
ബേസിക് ഇതിന്റെ പ്രത്യേകത പറ്റൂലേ?
അതിൽ കേൾക്കുന്നുണ്ടോ
ഞാൻ അത് കേൾക്കുന്നുണ്ടോ?
കേട്ടില്ലല്ലോ. കേൾക്കാമോ സർ?
കേക്കാം. ഓക്കെ.
ഞാൻ ഇപ്പൊ കോഹോസ്റ്റ് ആക്കിയിട്ടുണ്ട്. അപ്പൊ മ്യൂട്ട് ചെയ്യാൻ പറ്റുന്നുണ്ടോ നോക്കുമോ അവര്?
മാള് കോഹോസ്റ്റ് അല്ലേ ഇപ്പൊ?
എല്ലാം കോഹോസ്റ്റ് ആക്കിയിട്ടുണ്ട്. അപ്പൊ
അതായത് അപ്പൊ നമ്മൾ ചെയ്യേണ്ടത് ഈ കോഹോസ്റ്റ് ആക്കാൻ വേണ്ടിയിട്ട് ഇനിയിപ്പം ഓരോരുത്തർ ലോഗിൻ ചെയ്യുന്നവരെ കോഹോസ്റ്റ് ആക്കാൻ വേണ്ടിയിട്ട് ഈ കോഹോസ്റ്റിന് പറ്റൂലേ?
പറ്റും.
ഓക്കെ.
സൂമിൽ കേൾക്കുന്ന നല്ല ലാഗ് ഉണ്ട് ഇതിനകത്ത്.
ആണോ?
നല്ല ലാഗ് ഉണ്ട്.
2 minutes ലാഗ് എന്തായാലും ഉണ്ടാവും.
അല്ല യൂട്യൂബിൽ ഒരു 20-30 minutes അല്ല 30 seconds ഡിലേ വരും.
അത് കുഴപ്പമില്ല, അത് അക്സെപ്റ്റഡ് ആണ്. ഓക്കെ.
ഇങ്ങനെയാണ്
മറ്റേ സ്ലൈഡ് ഷോ എടുത്തു. ഇപ്പൊ ശരിയായില്ല.
ഇനി നമ്മൾ ഇതിനകത്ത് ഓഫ് ചെയ്തേ.
ഹലോ മാഡം.
സ്ക്രീൻ ഷെയർ ചെയ്യും
സർവാണി മാഡം
മാഡം
കോഹോസ്റ്റ് ആക്കി
പോസ്റ്റ് ഒക്കെ.
അല്ല
No, Cecil, don't make me co-host here. I'll reach and
Yeah.
give you a call, then make me co-host.
ഓക്കെ മാഡം
Okay, yeah.
Okay.
Because I'm just now traveling. Yeah.
ഓക്കെ മാഡം സോ സോ ഏത് കാര്യക്കാണ്
6 participants.
ഓക്കെ ഏതൊക്കെയാണ് അല്ല ഇവിടെയുള്ള വ്യൂ വരുത്തി യെസ് അൺമ്യൂട്ട് ഓക്കെ മ്യൂട്ട് ചെയ്യാം ഓക്കെ നമുക്ക് എല്ലാവരും മ്യൂട്ട് ചെയ്യാൻ പറ്റില്ലെന്ന് അറിയണേ കാരണം എന്താ വെച്ച് കഴിഞ്ഞാൽ നിങ്ങൾക്ക്
മാളും അടുത്തൊക്കെ ഹോസ്റ്റ് ആക്കാൻ പറ്റുമെന്ന് നോക്കാവോ? ഞാനൊരു മാളും അടുത്ത കോഹോസ്റ്റ് മാറ്റിയായിരുന്നു. അവിടുന്ന് കോഹോസ്റ്റ് ആക്കാൻ പറ്റുമെന്ന് നോക്കാവോ?
പറ്റുന്നില്ലല്ലോ. ഒരു കാര്യം ചെയ്യാം, നമുക്ക് ഇവിടുന്ന് ഈ കമ്പ്യൂട്ടറിൽ നിന്ന് RCC ലോഗിൻ ചെയ്താലോ?
അല്ല ഞാനല്ല ഈ RCC ലോഗിനെ ഞാൻ ഹോസ്റ്റ് ആക്കാന്ന്.
അതെ അത് മതി RCC ഇപ്പൊ ഇവിടെ ഇരിക്കുന്ന SRനെ ഇവിടെ ഹോസ്റ്റ് ആക്കിയാൽ
യൂട്യൂബ് ഇപ്പോൾ ഓൺ ആയി കിടക്കുകയാണോ അവിടെ?
യൂട്യൂബ് ഓണാ?
അല്ല അതിന്റെ സൗണ്ട് തിരിച്ചു വരുന്നുണ്ട്.
ഇല്ല അതിപ്പോ മൊബൈൽ ഇവിടെ റിങ് ചെയ്താ. ഇവരെ ഇത് ഹോസ്റ്റ് ആക്കിയാൽ മതി. അത് മൊബൈൽ ഓഫ് സൗണ്ട് ഓഫ് അല്ലേ? ഓക്കെ മേക്ക് എ കോസ്റ്റ്. ഓക്കെ
പറ്റി.
പറ്റി.
റൈറ്റ് ക്ലിക്ക് തന്നെ അവിടെ
ഇപ്പൊ ഇവിടെ ഒരു ഓപ്ഷൻ വരും. യൂട്യൂബിൽ എത്ര പേരുണ്ട് ഇപ്പൊ? അതെങ്ങനെയാണ്?
60 വാച്ചിങ് നൗ. ആരൊക്കെ വാച്ച് ചെയ്യണമെന്ന് അറിയാം. അറിയാൻ വേണ്ടി അത് ആരെ അറിയാൻ പറ്റും?
നമ്മുടെ സൗണ്ട്
സ്ട്രീം ചെയ്യുന്നവർക്ക് അത് ആരൊക്കെ വായിക്കുന്നു സ്ട്രീം
ഇപ്പോഴേ വെച്ചിരിക്കുന്നു.
ഇപ്പോഴത്തെ ലോങ് എഞ്ചിനായിരിക്കും
സാർ പറയുന്നതേക്കാം.
ഇതിന്റെ പൊളി ഇതിനകത്ത് പൊളി വെച്ചോ അല്ല
Good evening, all. Since there is a delay between YouTube and Zoom, we are starting the meeting at 5 p.m. We are delighted to welcome you all to the Head and Neck Clinical Oncology Symposium 2024, hosted by RCC Thiruvananthapuram.
This year's topic is HPV positive carcinoma oropharynx. We are proud to have a lineup of distinguished faculty speaking to us on the topic. To start off the first session on workup and staging of HPV positive carcinoma oropharynx, I invite Dr. Rajnishar Kumar, Additional Professor and Chief of Head and Neck Radiation Oncology, RCC Thiruvananthapuram. Over to you, sir.
Thank you. Thank you so much. Once again, before I start off with the presentation, let me just make a small introduction. And a very good evening to you all. And we thought at the department we would do this small topic on head and neck in oropharyngeal cancers, especially HPV positive cancers. It's one area where one subset of cancers where there has been a lot of changes that's been happening, though not exactly in terms of treatment. So today on our all the consultants who are presenting here, I'm sure Dr. Sarbani wouldn't require any introduction to this particular group of doctors, where because she's one of the most prolific consultants and teachers in India right now. And then Dr. Cecil Thomas, Dr. Malu Rafi, Dr. Lekha Nair, and myself, we formed the clinical oncology team in RCC doing head and neck. And we are ably supported by our physics department, and Dr. Saju Basi, who's also a speaker today, is one of the senior most radiation physicists who does a lot of support for us in terms of treatment planning. And so is the speaker, our radiologist, Dr. Priya, who does a lot of help with us for the radiology using the tumor boards and all the the radiological part. So we welcome all of you for the symposium today. And I think Dr. Priya is joining us a little bit late, so I thought I will start off with the workup and staging of oropharyngeal cancers. Just a small brief explanation on the anatomy of oropharynx. Oropharynx is a small tubular structure which connects the oral cavity and the nasopharynx to the pharynx and esophagus below. It is bounded anteriorly at the junction of the hard palate and soft palate, and superiorly by the mucosa of the soft palate, and posteriorly by the posterior pharyngeal wall. And the posterior pharyngeal wall, you must understand, is that it's a area which extends right from the base of the skull up to the lower level of C6 vertebra. And inferiorly at the tip of the epiglottis is that is where the oropharynx is. And this includes the base of the tongue, the vallicula here and the uvula, the soft palate with the uvula and the palatine tonsils and the posterior pharyngeal wall corresponding to the area of the oropharynx. If I go straight away into the staging and workup, I think I'll finish off my whole talk in 3 minutes. So I thought first I should explain to you why the cancer staging and the key principles of cancer staging. First, you need a lot of experts who represent all the entities of cancer staging and cancer biology. Actually, there is the AJCC Head and Neck Task Force has 28 members, and it is with a lot of inputs from all of them that every time a staging comes up, and if at all there is a modification, all these people are involved in the modification of the staging system. Second, you need data. What are the types of data that you need? You need pathological data, saying what all type of histologies you can get in each site, not only oropharyngeal cancers, in every site. Then you require the clinical data of patients and obtain in all patients. And there are a lot of treatment decisions which are made based on pathological and the clinical data. And you have to see how important and you have to recognize the implication of this treatment decision on the available data. So to validate any new staging system, you have to have all these things to validate a staging system. A few terminologies that you have to be aware of is the staging. It should have similar survival for each subgroup. This is called as hazard consistency. And each subgroup should have a different survival from one level above it and below it. This is called as hazard discrimination. So it means that you should be able to discriminate between the different stages. It should be relatively equal numbers in each group for better statistical comparison. That is, all the groups should be well balanced, and you should have a high predictive ability. Whatever staging that you are coming up with, the stage should give approximation of the prognosis and survival. So that means that it should have high predictive ability. So with each recommendation for stage change, the data is revisited to make sure that these principles are being followed and supported. So it is not a one-time process. It is an iterative process. So it does, every time new data emerges, then you have to go in, just like how it has happened in HPV positive diseases. It is not a one-time process that you finish off the staging in one sitting. But depending upon the new data that is coming up, you keep changing the staging process if required. Why did they separate this oropharyngeal carcinomas depending upon the HPV status? You see that since 1990, the incidence of HPV-associated cancers, basically the base tongue and tonsil, has increased by almost 5% every year. So that's a huge number of increase in the incidence of HPV positive diseases. And usually these are associated with younger patients, who are healthier individuals with little or almost no tobacco exposure. And most importantly, it's a highly responsive disease, and the responsive treatment, and it has an excellent prognosis. So you cannot just club it with all the other oropharyngeal cancers and put it in one single basket. The 7th edition of the TNM staging in oropharyngeal cancer, it reflects only the tobacco-related squamous cell carcinoma and not the HPV-related positive disease. And the 7th edition actually lost the ability to differentiate between the stages, that the hazard discrimination was lost. And the numerical balance, it shifted towards stage 3 and stage 4 diseases. In early stage diseases, even though there was no difference in treatment, and of course, even in later stage, right now, there is no difference. But the numerical balance shifted towards the stage 3 and stage 4 disease. And the 7th AJCC staging lost the predictive ability. Just a slide on the how these HPV positive and negative patients they are. Usually HPV positive patients are younger, middle-aged people, and HPV negative are above 60 years, usually the causative factor is usually altered sexual behaviors. And in the negative ones, it is basically tobacco and alcohol. Field cancerization is unknown in HPV positive. Usually the predilection site is the oropharyngeal disease. And as always we say, they usually present with lower T stages and a higher nodal status in HPV positive diseases. And the histology is usually a poorly differentiated carcinoma in HPV positive disease. Here you see the NCCN guidelines, which very clearly tells us what the workup and what all investigations have to be done in HPV positive oropharyngeal cancers. Just to put it simply, I would put it on one single slide where biopsy is absolutely necessary whenever possible from the primary disease itself. And you have to do a P16 assay for these on this biopsy material. Complete blood count, renal function, and liver function test is necessary because most of these patients would go in for a chemoradiation protocol. And the most common, the most preferred imaging modality is an MRI in oropharyngeal cancers. At least an X-ray of the chest is to be done. But in cases where there are level 4 nodes or an N3 node, a CT thorax or even a PET CT might be useful. And the dental prophylaxis is definitely indicated because all these patients will go in, most of these patients would go in for a chemoradiation protocol. The guidelines from the College of American Pathologists, it very clearly tells us when HPV testing is to be done. And there is clear evidence to be recommended when routine testing is indicated. And P16 is the recommended method of testing for high-risk HPV in oropharyngeal cancers. And HPV is, most importantly, it is an important and independent predictor of overall survival and specific and disease-specific survival for oropharyngeal cancers. This has been endorsed by the CAP guidelines by ASCO also. And HPV, as for the testing of HPV, it must be a simple, inexpensive, reproducible test, and it needs to be available worldwide. And hence, immunohistochemistry for the overexpression of tumor suppressor protein P16 has been established. It's a reliable surrogate marker. It's an independent positive prognosticator of oropharyngeal cancers. It is inexpensive and widely available and easy to interpret. So from here onwards, oropharyngeal cancers will be staged according to two distinct systems, either depending upon whether they're positive, HPV positive or HPV negative. And overexpression means it is diffuse more than 75% of tumor expression with at least +2 or 3 staining intensity. This is a very busy slide, I know, but here the main 3 things that you have to understand is that here, when all will you do HPV staining? In immunohistochemistry for HPV is done in all oropharyngeal cancers, in metastatic neck node of unknown origin, where the primary is unknown, and where you want to see whether it is an HPV-related tumor or not. It is in those, the second set of where you would do HPV testing, and in those areas of primary disease where the primary is extending either from the oral cavity to the oropharynx, or from the larynx to the oropharynx, or from the oropharynx to the larynx, when you're not sure. And HPV testing should be done to make clear whether it is of an whether the site of origin is of oropharyngeal or not. P16 positivity is actually a surrogate marker of HPV infection. It is not a highly specific, but for now, P16 positivity with immunohistochemistry is accepted for labeling a tumor as HPV positive. But all these changes, as the HPV infection happens, then there is viral integration, viral transcription, and then translation, and it is then that the HPV protein starts being detected. But the more specific investigation would be to assess the E6 or the E7 mRNA by FISH technique. I think I wouldn't go too much on putting up tables. Rather than that, I would put up more CT scans and MRI pictures just to make it more easily understandable. In this, when we did a PET scan, you can always see that there is a lymph node here, a necrotic lymph node here on the in the 2B region. And many of us would definitely miss out a small enhancement. Only when you see the PET scan would you see that there is also a small uptake in the lighting up of the primary lesion in the oropharynx, which would easily go missed on a regular CT scan in an HPV positive disease. Again, to show that it's a small positive primary disease and a larger lymph node. Same way here also, even though the cuts are of a little at the slightly different levels, you see that there's a large cystic necrotic node, and which lights up here on a PET scan, and a very small primary. This is again to show that most of the HPV positive diseases present with small primaries and with a large lymph node. Coming to the staging of head and neck, the oropharyngeal cancers, basically the small early stages are no different. T1 tumors are, this is a T1 tumor, so it is 2 centimeters or smaller in greatest dimension. Or here you can see 2 to 4 centimeters, more than 2 centimeters, but not more than 4 centimeters in the greatest dimension. So in oropharyngeal cancers, be it P16 positive or negative, there is no difference in the T staging of these diseases. Just to show this, again, there's a small primary disease in the tonsil here, and here in the vallicula. There's a small primary disease in the vallicula. Even T2 disease, there's a small disease here in the vallicula on the sagittal section. You can see this reaching up to the vallicula. And here it's a T3 disease because it involves the laryngeal surface, the oropharyngeal surface of the lingual surface of the epiglottis. So it's a T3 disease. Even here, there is no difference in the staging of T1, T2, T3. There is no difference in whether be it P16 positive or negative. It is when you come to stage 4 diseases that the difference starts appearing. In HPV negative diseases, stage 4A is involvement in the larynx, the extrinsic muscles, the tongue, the medial pterygoid, the hard palate, and the mandible. These qualify to become a stage 4A disease. And 4B is when the lateral pterygoid is involved, the pterygoid plates are involved, the lateral wall of the nasopharynx is involved, or be it the skull base, or whether it in cases the carotid artery. You must understand that there is no T4A or T4B in HPV positive carcinoma oropharynx, because even in such advanced diseases, the outcome is much better. That is why the whole staging system has been changed. Again, here you can see the axial cut showing a disease in the vallicula extending to the supraglottis here, and the same thing which is shown in the sagittal section where there is a laryngeal infiltration. There's a laryngeal infiltration. Regularly in a HPV negative disease, this would be classified as T4A, but in HPV positive, it would only be taken up as a T4 disease. There is no A and B differentiation here. Same way, another showing the involvement of the extrinsic muscles of the tongue. Here also, it involves even the anterior to the tongue, the mandible probably. There's an MRI, so the mandible probably is also involved, and even the retromolar trigone is involved. And again, in HPV positive, it just becomes a T4 disease. So be it. Here also, you can say that there is a nasopharyngeal extension, because it is in the cut of the nasopharynx with a small lateral pharyngeal lymph node. Here also the pterygoid plates, the medial pterygoid, the lateral pterygoid, the pterygoid plates, everything is involved with a small lateral pharyngeal lymph node is involved. Even then in HPV positive disease, it becomes it's an advanced CA oropharynx, and HPV positive, it becomes only a T4 disease without a subclassification of T4A and T4B. Again, to show that it's an advanced disease here, and here also it's an advanced, the primary is advanced with bilateral nodes, level 2 nodes here, and on the opposite side, still it becomes, I'll come to the nodal staging more specifically in the next few slides. But again, here it becomes a T4N2 disease only, and in HPV positive disease. The masticator space has always been very detrimental space because the involvement of the masticator space carries a very poor prognosis. When in oral cavity cancers, you can see that when the medial pterygoid, the lateral pterygoid, or the pterygoid plates are involved, it straight away goes into T4B disease. And in HPV negative, the medial pterygoid is T4A, and the lateral and pterygoid plates becomes a T4 disease. So just to compare the other side, there is a nasopharynx where there is more involvement of the pterygoids. It only becomes T2 and T3 in the nasopharynx. But in HPV positive oropharynx, whatever be the masticator space involvement, it becomes only a T4 disease. And in nodal staging, when you come to nodal staging, N1 disease, which is a single, or even if it is a multiple ipsilateral lymph node, if not more than 6 centimeter, you can see that it becomes only N1 disease, and still it is only a stage 1 disease. This line I have put is to show that below the level 4 node in carcinoma nasopharynx would bring it up to N3 stage. And in HPV negative disease, the presence of one single lymph node raises a standard to level stage 3. The staging goes up to stage 3. And in HPV negative disease, you can see bilateral disease of contralateral nodes brings it to stage N2C, and it straight away it goes to stage 4A. Whereas in HPV positive disease, N2, that is bilateral contralateral even with multiple lymph nodes in the same site, with bilateral or contralateral nodes, if it is not more than 6 centimeter, there is no subclassification of N2 to N2A, B, or C, but it is only N2, and still the stage is the composite staging will fall at stage 2. Just show a few scans here. You can see a node here and here. In HPV positive, it is still N2 stage 2 disease, whereas in HPV negative, these two nodes with bilateral nodes, it will go into N2C and straight away go to stage 4A. And in N3 disease, you can see that in HPV negative disease, there's a classification of N3A and N3B depending upon whether there's an extracapsular extension. And in HPV positive disease, there is no extracapsular extension which has been taken into consideration. And even with an N3 node in HPV positive, it becomes only a stage 3 disease. Even in CN nasopharynx, it would go up to stage 4A. In a case of metastatic neck node of unknown origin, when the patient has undergone a neck dissection, you can see that in the postoperative reporting, when you see in HPV positive disease, there is only PN1 and PN2. N1 is metastasis to 4 or fewer lymph nodes, and N2 shows that it's metastasis in more than 4 lymph nodes. There is no PN3 in HPV positive disease, and the size is immaterial in post-op cases, and extracapsular extension is not taken into account. That is the most important thing, and still it falls only into stage 2 disease. Again, a few slides showing that the primary in HPV negative disease, if it's a T2 N1, it is a stage 3 disease, whereas even in an HPV positive one, it is stage 1 disease. And again, here it's a T2 disease with a large lymph node, but it is less than 6 centimeter. Still, it's a stage 1 disease. And here also there is a tonsillar growth with multiple bilateral node and less than 6 centimeter. In HPV positive, again, it is a stage 1, and in HPV negative, it becomes a stage 4 disease. Again, I'm reiterating the fact that the size of the lesion, the size of the node, the number of nodes, and extracapsular extension has not been taken into consideration because still they have a good prognosis for HPV positive disease. Here you can see that there is a T2 disease with, if you see these two nodes, it is an N2C in HPV negative disease. And in HPV positive, even these multiple nodes again brings it only into T2, N2 disease. It's again a stage 2 disease. And T4A, you see, is a moderately advanced local disease where the tumor invades the larynx, the extrinsic muscles of the tongue, the medial pterygoid, heart palate, and the mandible. And T4B is a very advanced local disease where the lateral pterygoid muscles, the pterygoid plates, lateral nasopharynx, skull base is involved. Again, to show that this lesion involves the extrinsic muscles of the tongue. Here, again, to show that it involves the pterygoid plates and the pterygoid muscles. There is no subclassification. But this is also to show that there is an involvement of the genioglossus muscle here, again, to show the multiple lymph node involvement here. So they have simplified the clinical staging by the number of lymph nodes is no longer significant in HPV positive disease, and extracapsular extension is not included. So just coming on to almost my last slide, I think is it's a composite group where in stage 1 in HPV positive carcinoma oropharynx, any T2 up to N1 still is a stage 1 disease, whereas only T1 N0 is HPV negative in stage 1. In stage 2, even T3 or N2 is stage 2. Here it's again T2 N0, and even a T4 or N3 disease becomes only stage 3. Whereas here it is either T3 or any N1 becomes stage 3. And only a metastatic disease in HPV positive diseases makes it stage 4A disease, whereas T4A and N2 diseases in HPV negative is stage 4A, and 4B is T4B, N3, and stage 4C is M1. Here there is no classification of stage 4B and 4C here. Thank you.
Thank you, sir, for that beautiful session. Shall I, there is a question in the chat box, sir. Shall I read it out for you?
Yeah.
So Chandrima Mukherjee has asked, in the principles of staging, the point about the numerical balance, how can that be ensured between different populations, since it would drastically vary with populations?
That is why you have to take the clinical data of all the patients, where you have to take clinical, not only the pathological data. It is only after revisiting all these things can you make any changes. It is not that you will make change with just one population. You have to revisit all these changes. You have to revisit, and only then can you come to a conclusion on whether this change is required or not.
Thank you very much, sir. To continue on to the next session regarding the current status of de-intensification strategies in HPV positive carcinoma oropharynx, I would like to invite Dr. Malu Rafi, Associate Professor, Department of Radiation Oncology, RCC Trivandrum, for the session. Over to you, ma'am.
Thank you, Livia. I think, sir, you need to stop sharing your screen. Yeah. So good evening, everyone. And this evening, I'll be talking on the current status of de-intensification strategies in HPV positive oropharyngeal squamous cell carcinomas. So this is a rather long talk with a lot of trials and data that I'll be discussing. And I really hope that I don't put you all to sleep. So let me begin with this figure, which was published in 2010 by Professor Kianang, and which brought out the superior survival of HPV positive cancers when compared to the other head and neck squamous cell cancers. And we now know that HPV related tumors are a distinct entity, and you've already seen this in Rajni sir's slides. And most patients are young with no tobacco or low PAC years, in good general health. And we also know that they carry excellent survival outcome with 3-year overall survival of 82.4% reported for these tumors compared to the 57.1% for the other head and neck cancers as reported by Professor Rang in the same paper. So he also risk stratified these tumors based on the smoking history to low, intermediate, and high risk, and brought out the differences in survival based on the risk stratification based on pack years. So coming to the treatment options for oropharyngeal cancers, for early stages, the standard of care is currently external beam radiation over 6 to 7 weeks. And the upcoming options include transoral robotic surgery, transoral laser microsurgery, which are now gaining momentum in many places. For locally advanced stages, it is combined modality treatment, which is a standard of care with 6 to 7 weeks of EBRT and concurrent cisplatin, or EBRT over 6 to 7 weeks with cetuximab in patients who are cisplatin ineligible. There is also an option of TORS with neck dissection plus with or without adjuvant treatment based on the pathology report. Now, the radiotherapy-based options are time-tested, supported by evidence, and these are currently the standard of care for oropharyngeal squamous cell cancers. So we know that these patients are younger, they have long survival, and this long survival is often offset by the late toxicities of the traditional chemoradiation approaches. So now it is in this context that the various de-escalation protocols have been developed in order to strike a balance between survival and development of late toxicity. So now I have divided the various strategies for de-intensification based on EBRT-based approaches as well as surgery-based approaches for ease of description. So the various EBRT-based approaches include replacing or omitting cisplatin, de-escalating the EBRT or chemo dose, adaptive dose volume modification approaches, which are the personalized approaches, which could be based on various theories. Then you could try reduced EBRT volumes. Then another strategy is neoadjuvant chemotherapy and response-based approach. And yet another strategy is replacing photons with protons. Then the surgery-based approaches include primary TORS or TLM for early cases and tailored adjuvant treatment. And for locally advanced cases, it includes primary surgery and reduced adjuvant treatment based on the HPR. So now let's examine each one of these approaches. So the EBRT-based approaches, we'll first have a look at replacing or omitting cisplatin as a whole. So the rationale for this comes from this landmark paper, which proved the superiority of cetuximab compared with radiotherapy alone in locally advanced head and neck cancers who were cisplatin ineligible. So it is based on this that the RTOG did this trial, RTOG 1016, which is a phase 3 randomized multicenter trial, which randomized around 1,000 patients who belong to the low and intermediate risk stratification, HPV positive oropharyngeal cancers, to the standard 70 gray IMRT with cisplatin and a study arm of 70 gray IMRT with cetuximab. And they had a primary endpoint of overall survival and several secondary endpoints, progression-free survival, locoregional failure, distant metastasis, and also treatment-related adverse events and quality of life. So when the overall survival was reported, we could find that the 5-year overall survival was superior for the cisplatin plus radiotherapy arm, and the same was reflected in the progression-free survival as well. And when in the toxicity report, we could see that the toxicity profiles were different for both arms, with radiation dermatitis, acneiform rash being more common for the cetuximab arm, and neutropenia and other complications like renal injury and hearing impairment more common for the cisplatin arm. So yet another trial which tested the same strategy was the de-escalate phase 3 trial, which randomized 333 low risk HPV positive patients to 70 gray plus cisplatin and 70 gray IMRT plus cetuximab. And their primary endpoint was overall acute and late severe toxic effects at 2 years. And secondary endpoints were overall survival, time to recurrence, and also quality of life and late toxicities. So when this trial was reported, we could see that there was no difference in the toxicity profile of the two arms, but the same findings of superior survival for cisplatin plus radiotherapy was found in this trial as well. Then the third phase 3 trial was a TROG trial with a similar design of 70 gray plus cisplatin versus 70 gray plus cetuximab, but this was a smaller trial, around 200 patients, with a primary outcome of symptom severity, comparison between baseline and 13 weeks post completion of RT. Again, at a median follow-up of 4.1 years, there was no difference in the primary endpoint of symptom severity, and the 3-year failure-free survival was also higher for the cisplatin plus RT arm. So based on these results, RT plus cisplatin remains the standard of care with no proven advantage of replacing cisplatin with cetuximab. Now, I'm going to discuss the next approaches together because there are a host of other trials which have tested these approaches either as a single approach or multiple approaches were combined in one study. So I'm going to discuss them together. That is de-escalating EBRT and chemo, or going for adaptive dose volume modification, or the personalized approaches, as well as a reduced EBRT volume approach. So one of the first attempts for this was done by the NRG Oncology HN002 trial, where they randomized HPV positive low-risk patients to IMRT plus cisplatin, 60 gray IMRT plus cisplatin, or 60 gray IMRT alone in a phase 2 non-inferiority design. And their endpoints were 2-year progression-free survival and MD Anderson dysphagia inventory score, and also the 2-year overall survival rates. So they found that at 2 years, the IMRT plus cisplatin arm had superior survival, and the MD Anderson dysphagia inventory scores were also not very different. And so the IMRT alone group did not meet the acceptability criteria which they had defined. So the same group went on to do the HN005, which is a phase 2 and 3 non-inferiority trial, where they are randomizing patients to the same inclusion criteria. Patients are randomized to either one of the 3 arms. They incorporated the standard treatment arm of 70 gray IMRT with concurrent cisplatin, and 2 study arms of low dose 60 gray IMRT with cisplatin and 60 gray IMRT with nivolumab. And in this trial, they have also used ipsilateral volumes for lateralized tumors, and their primary objective is defined as progression-free survival, and they have secondary endpoints of quality of life as measured by and quality of life as measured by the MD Anderson dysphagia inventory. And we are waiting the results of this trial. So now let's look at this trial, which is a phase 2 trial of de-intensified chemoradiation therapy for favorable risk HPV oropharyngeal cancers. So this is based on AJCC 7th edition staging, and they have tested a 60 gray IMRT plus low dose, that is 30 milligram per meter square cisplatin given weekly, and they aim to assess the complete response rate as assessed by PET-CT. And at a median follow-up of 14 months, they have reported a 98% complete response rate for primary and 84% complete response rate for nodal sites. So the same group have went on to do a follow-up study, which is a phase 2 trial testing 60 gray IMRT with cisplatin 30 to 40 milligram per meter square as first choice. And this trial also allowed the use of cetuximab or carboplatin at AUC 5 along with Pacli 45 milligram per meter square. And these results of this trial is awaited. So then there are also other strategies which are being tested. So one of that is actually hypoxia-based stratification. So that there is a major de-escalation trial which aims to de-escalate treatment to 30 gray RT and cisplatin. So this study uses 18 fluoro-F-meso-PET for assessment of hypoxia, and HPV positive favorable risk patients without hypoxia are given a dose of 30 gray RT and cisplatin. And patients who have hypoxia are started with chemoradiation with a repeat imaging in 1 week to reassess hypoxia. And if there is no evidence of hypoxia at 1 week, RT is de-escalated at 30 gray. And in case of patients with persistent hypoxia, they're taken up to 70 gray along with concurrent cisplatin. And this trial uses IMPT protons for all patients. So their objectives include 2-year loco-regional control, progression-free survival, and overall survival. And it was reported to be 100%, 92.9%, and 92% respectively. So this was, now this is the next protocol, which is in a trial phase, which is again a phase 2 trial of a or interim PET-CT based response assessment, where all patients undergo a pre-treatment PET as well as an interim PET. And the study arms include 70 gray IMRT with weekly carbo and Pacli. Is a standard arm, sorry, and the study arm, and in patients who meet interim PET defined response criteria, their RT is de-escalated to 54 gray in 27 fractions and 43 gray in 43.2 gray in 27 fractions to high and intermediate risk PTV along with concurrent chemo, and they aim to look at the loco-regional recurrence. Again, we are awaiting the results of this trial. So yet another strategy is an MRI-based adaptive replanning as tested in the MD Anderson MR adapted trial, which is again a phase 2 trial being done in low-risk HPV positive cancer patients who have only nodes in level 1 to 3. And this this trial aims to test the feasibility of MRI-based adaptive replanning versus standard IMRT, and their primary objectives are loco-regional control and dysphagia outcomes, and also they have a host of secondary objectives. So another strategy which is upcoming is the genomic-based risk stratification. So there is a trial which tried to look at the negative and positive predictive value of circulating HPV DNA as a predictor of outcome. And based on this, we have a phase 2 single arm study which attempts to de-escalate chemoradiation treatment based on mid-treatment tumor response as determined by nodal shrinkage and clearance of circulating HPV plasma tumor DNA. So this trial is being done with an objective of progression-free survival at 2 years. Now coming to the trials which are testing the reduced volume EBRT. So we have a phase 2 EVADER trial, which is a trial testing elective volume adjusted de-escalation in patients with low risk HPV related cancers. So they are testing primary definitive chemoradiation or chemoradiation with volume reduced elective nodal irradiation. So now the next approach that I would like to discuss is neoadjuvant chemo and response-based approach. So we have this phase 2 trial, which is the ECOG Akron research group, cancer research group trial, in which patients with low risk cancers were given induction chemo with paclitaxel, cisplatin, and cetuximab for 1 to 3 cycles, and complete responders were de-escalated to 54 gray and weekly cetuximab, and incomplete responders were given up to 69.3 gray along with weekly cetuximab. So this trial has reported reasonable survival outcomes for the de-escalated group. Now, then we have the quarterback trial, which is both phase 2 and 3. We have the results of phase 2 and the phase 3 results are pending, which is a de-escalation chemoradiotherapy for a similar subgroup of patients, but the induction treatment is TPF. This is a dose-reduced TPF schedule that was used in this trial. And patients with complete response or partial response were randomized in a 2:1 fashion to IMRT with 56 gray or IMRT with 70 gray along with weekly carboplatin. Now, in the phase 3 part of this trial, they have randomized low-risk patients with partial or complete clinical response to 56 gray with concurrent carboplatin and high-risk patients with no response or progression to surgery or the standard treatment of 70 gray RT with concurrent carboplatin. So for the phase 2 results, at a median follow-up of 56 months, the 3-year progression-free survival was 87.5 and 83% for the 2 study arms. Now, next is a phase 2 trial, which is called as the Optima trial, which tested 3 cycles of induction chemo with carboplatin and nab-paclitaxel, and responders with more than 50% response were given 50 gray RT, and if 30 to 50% clinical responders were given 45 gray along with concurrent paclitaxel, and those with inadequate response were treated to 75 gray and concurrent paclitaxel. So again, high-risk patients, all of them were given concurrent chemo, with those with favorable responses getting 45 gray and less than 50% response getting 75 gray. So we have the results of this phase 2 trial with low-risk patients progression-free survival of 95 and overall survival of 100% in the study arm. And for high-risk patients, having a progression-free survival of 94 and 97% in the de-escalation arm. So there is the ongoing Optima 2 trial, which is again a phase 2 trial, which have combined carbo, nab-pacli and nivolumab, and risk stratification is based on the clinical response and staging. So responders are and TORS eligible patients go on to have TORS and reduced adjuvant treatment. And in a TORS ineligible patients are given reduced RT of 50 gray. And again, less favorable responders go on to receive 50 gray with concurrent cisplatin, and very bad responders get 75 gray and cisplatin. So for high-risk patients, it is 50 gray and concurrent cisplatin and 75 gray and concurrent cisplatin for responders and non-responders. So, and all patients will be offered adjuvant nivolumab for 6 months post completion of definitive therapy. So the last of the EBSC-based approaches which is being tested is replacement of protons with photons. So we have a phase 2 and 3 trial, which tests the benefit of replacing 70 gray IMRT with 70 gray IMPT, density modulated proton. And in this trial, the use of chemotherapy is left to the discretion of the treating physician. Now, coming to the surgery-based approaches, I'm not going into great details into this because I think Sabani Madam will be giving an extensive talk on this. So we have the primary TORS and TLM for early cases and tailored adjuvant, as well as primary surgery plus reduced dose adjuvant based on HPR. I'll just rush through the slides. So we have the Orator trial, which was the first of the phase 2, first of the trials which tested TORS and cisplatin, and they looked at the MD Anderson dysphagia inventory score at 1 year and found no difference. And we have the Orator 2 trial, which is attempting to randomize stratified by smoking status into 60 gray with weekly cisplatin and transoral surgery plus adjuvant RT 50 to 60 gray based on risk factors. So for surgery followed by risk-adapted adjuvant treatment, we have a host of trials like the ECOG 3311 trial, which tried to risk stratify, and for low-risk patients, observation. For intermediate group patients, 50 and 60 gray versus high-risk patients getting 66 gray. Then there is the MC1273 trial, which used a very de-escalated schedule of 30 gray and docetaxel for ENE negative patients and 36 gray along with concurrent docetaxel for ENE positive patients. So then there is the ongoing Pathos study, which is a phase 1 to 2, phase 2 and 3 trial, in which patients are stratified into low, intermediate, and high risk after surgery based on the HPR. And group A patients are just observed. Intermediate risk patients are given 60 gray postoperative or 50 gray in 25 fractions postoperative RT, and high-risk patients are randomized to 60 gray with concurrent cisplatin or 60 gray alone. So again, we are awaiting the results. Another phase 3 trial which we look forward to is the ADEPT phase 3 trial, where they are randomizing 60 gray in 30 fractions IMRT as adjuvant versus 60 gray along with weekly cisplatin at 40 milligram per meter square following surgery. So we also have trials of alternative volumes for de-intensification, or the AVOID trial, in which the adjuvant treatment based on the HPR is limited to the involved neck alone with sparing of the primary tumor bed. So these are the other trials which are yet to be reported. The minimalist trial, or the MINT trial, in which post-operatively they are stratified to low and intermediate risk and treated up to 42 gray or 42 gray with 1 dose of cisplatin or 60 gray with cisplatin for the intermediate group. Then we also have the DART HPV trial, which is actually a follow-up phase 3 trial of the previously mentioned MC1273 trial, testing 30 gray with docetaxel for ENE negative versus 36 gray plus docetaxel for ENE positive, compared to 60 gray plus cisplatin as a standard adjuvant treatment. So for those of you who are sleeping, it's time to wake up, because I'm coming to the take-home messages. This is where we started, if you remember. So the EBRT-based approaches, the first thing would be to replace or omit cisplatin. We have phase 3 data in the form of 3 trials, that is the RTOG, de-escalate, and the TROG trial. None of them have shown a benefit of replacing cisplatin with cetuximab. And we have a phase 2 trial, which is testing immunotherapy with RT. We are waiting the results. So for the other 3 approaches, we have 60 gray with or without cisplatin being tested in a phase 2 manner. Then 60 gray plus nivolumab being tested again in a phase 2 manner. And we have adaptive approaches, which are all being tested in phase 2 trials. So we have an interim PET-based approach, the circulating DNA-based approach, MR-guided adaptive radiation approach, and hypoxia-based extreme dose de-escalation up to 30 gray, which is again being tested in a phase 2 manner. And we have the volume-reduced elective nodal radiation, which is again in phase 2. Then for response and neoadjuvant chemo and response-based approach, all trials are in phase 2 status. So the various neoadjuvant schedules being tested include cisplatin, paclitaxel plus cetuximab, carbo plus nab-pacli, carbo, nab-pacli, and nivolumab, and also TPF. So we have protons replacing photons in phase 2 and 3 trials. The results are again awaited. So for surgery-based approaches, the ORATOR trial have failed to show any benefit for surgery in reducing dysphagia score. And primary surgery and HPR-based de-escalated adjuvant RT is mostly in phase 2 and 3, and most of them, the results are awaited. So that's all. Thank you for your patient listening.
Thank you, madam. Thank you for the interesting talk on various de-escalation strategies of HPV positive CA oropharynx. We don't see any questions in the chat box. Let us move on to the next session. Thank you, madam. Next topic is radiology of HPV positive CA oropharynx by Dr. Priya A, Associate Professor, Department of Radio Diagnosis, RCC Trivandrum. Over to you, madam.
Can you include the other one also? It's showing you have removed me. You have Can you include the other?
Yeah, can you log in again? Because
Okay, sir. Okay.
you're planning to have sound from the other maybe.
Oh.
Because if you involve both, then the sound there will be a echo will be there. So
Okay, sir.
if you are using two, then one you have to mute one. Okay.
Okay,
Fine.
sir.
Mm. We are extremely sorry for the technical issue. Priya, can you share now the screen?
Yes, sir. Are you seeing the first slide?
Yeah,
sir?
yeah. Can you?
Yeah.
Can you put in the slideshow?
Yes.
Yeah. Perfect.
Right now I'm using two devices. I hope it is not disturbing.
No
Is it
issues.
okay?
Yeah, please carry on.
No
Yeah.
issues.
Yeah.
Okay. So good evening, everyone. I'll be discussing in brief about the radiological anatomy of oropharynx and how HPV positive cancers are on imaging have a different appearance compared to the negative ones. So we'll start with little bit of the anatomy, and as we know that oropharynx is bounded superiorly by the hard palate. Soft palate junction is the cranialmost extent, and inferiorly it is the hyoid along with the vallicula. And this is the sagittal and the axial sections of I put to show the anatomy. So you can see that. So this is the hyoid bone in sagittal view. This is the hyoid bone. Cranial most extent, we take the junction between the hard palate. You can see this is the hard palate. This is soft palate. The hard and the soft palate junction until the hyoid bone along with the vallicula. So we take that as the cranial and the caudal extent, and anterior extent. We can't see the circumvallate papilla in imaging. So what we take is the junction. So if it is the hard and the soft palate junction, we draw a line, and that will be our anterior extent. Posteriorly, it is the posterior oropharyngeal wall. Just I want to show that in. Okay. So this is the sagittal images. I'll be scrolling. So we can see the base of the tongue here, and then this is the lingual tonsil related. Some radiology books describe this area as the root of tongue, but many of the treating physicians, they don't agree with that. So with that terminology, we don't use it, but you can see in some of the radiology textbooks that this is considered to be the they call it the root of tongue. You can see the lingual tonsil there, and then the vallicula. You never see a lingual tonsil extending to the posterior wall along the vallicula. So that is one weak hint that we are looking only at the lingual tonsil and not at as a mass, because sometimes this can confuse with the mass, so especially if it is enlarged. So that is one clue. So this is the vallicula, and there's the free surface of the epiglottis, which is also considered the lingual surface of the epiglottis, which is also considered part of the oropharynx. Okay. Okay, when it comes to the subsides, there are four subsides. One is the base of the tongue, which including the pharyngoepiglottic and the glossoepiglottic fold, which is nothing but this is the median and the lateral glossoepiglottic folds. So four subsides are the base of tongue, including the pharyngoepiglottic and the glossoepiglottic folds. Palatine tonsils, including the tonsillar fossa, anterior and the posterior tonsillar pillars, and the soft palate, including the uvula, and the posterior and the lateral oropharyngeal walls. Base of tongue, including the two folds, and then palatine tonsil, including the anterior and the posterior tonsillar pillar, in the soft palate along with uvula, and the lateral and the oropharyngeal wall. This is a diagram to show the base of tongue relation. So you can see this is the area that the extent, anterior extent we take is at the junction of the hard palate and soft palate junctions. You draw a line, and that is the area which demarcates the oral tongue from the posterior, from the base of tongue. The inferiormost extent is the hyoid bone, and this is the lingual surface of the epiglottis. This is vallicula, and this is the pre-epiglottic fat where the asterisk has been put. And you can see the median and the lateral glossoepiglottic fold, which is also called the pharyngoepiglottic fold. Posterior extent, we have the glossotonsillar sulcus. We can see it is a this is a T1 weighted image. So in T1, fat will look bright. So we can see there is a bright area there. So it normally contains little amount of fat. If this is effaced or if this is if this disappears, then we can think in terms of the tumor extending to the tonsillar region, anterior tonsillar pillar. So this, it look for this fat in this will be seen both in CT as well as in the T1 weighted MRI. So look for this, and posteriorly it is the tonsillar region, and more laterally, posteriorly and more laterally, we get the styloid muscles, styloid along the muscle attached with it. So when it comes to the spread pattern, so posteriorly it is the tonsillar region, that anterior tonsillar pillar, glossotonsillar sulcus, tonsillar fossa, and anteriorly it is the anterior tongue and floor of mouth. Inferiorly, it goes to the vallicula, the piriform fossa, the pre-epiglottic space, pre-epiglottic fat and everything. So laterally, we have seen in the previous image how the styloid muscles styloid and its muscles are related to it. It's more laterally and posteriorly it is related to the styloid muscles and carotid artery. So this is another diagram section to show how the styloid muscles, how it is related to it. So this is a slightly inferior section. This is at the level of genioglossus. That means we are at the level of floor of mouth, and you can see more laterally and posteriorly you have the styloid, the muscles of the styloid coming in close relation to the oropharynx. Then there's the second subset, that is the tonsil. You can see this is the axial T2 weighted image. You can see there is this is the tonsil, the palatine tonsil, along with the anterior and the posterior tonsillar pillars. And the deeper portion where the the tonsillar bed is there, that is the superior constrictor muscle comes here. And deeper to it, it is the parapharyngeal fat. So when compared to the tongue muscle, the base of tongue, tonsillar region, CA tonsil can have craniocaudal spread. You've seen in tongue how it goes anterior, posterior, and mediolateral. It can spread, but when it comes to tonsillar CAs, it can go craniocaudal extent is more. Why? Because of these two muscles. One is the palatoglossus and another is the palatopharyngeal, which is nothing but the anterior tonsillar pillar and posterior tonsillar pillar. How the palatopharyngeus is associated with the craniocaudal spread is because it has got a very close relation with the middle constrictor muscle, which will take it to the deeper infiltration into the pharyngeal muscles, other pharyngeal muscles. You can even see the erosion of the thyroid cartilage also. So this is about the palatopharyngeus muscle. Palatoglossus muscle, which is a part of the soft palate muscle. So when it comes to soft palate, there are other muscles in the soft palate, which are the tensor villi palatini and levator villi palatini. So these can have a they have attachment to the skull base near the pterygoid hamulus. So one can take the mass, the cranial extent to till the skull base, and other can have the deeper extent to the other muscles of the pharynx, and it can have a deeper extent. So when it comes to spread pattern, so it can go to superiorly if it goes to soft palate, other muscles of the soft palate, because palatal glossus itself is a muscle of the soft palate. So soft palate, and from there to the skull base, and anteriorly it can go to the tongue base. And okay, how retromolar trigone is related, because the superior constrictor muscle at the deeper portion, it has got an attachment to the pterygomandibular raphe. So where the buccinator muscle also gets attached. So it from there, so this can act as a cord. It can act as an easy route for the mass to reach the RMT. So it can go to the RMT, and from there to the buccal mucosa, because the buccinator also gets attached there. And then parapharyngeal fat, mandible, and then it can have a all direct extension. Apart from this, taking these ways of easier access to the skull base and pharynx, it can also have a direct extent. Okay, these are some pictures to show how the muscles of the styloid process are attached to the, this is the stylopharyngeus muscle, how we will know it, because once we start scrolling, this is a static picture. So once you start scrolling, you can see the muscle, a thin muscle, moving towards the, coming closer to the, this is at the uvula level. So it is cranial to caudal level. So you can see it is coming closer to the posterior pharyngeal wall. So that way the stylopharyngeus and the glossopharyngeal nerve involvement is also this is another picture just to show how the superior constrictor muscle is related to the tonsillar region. So when it comes to next, the third subset is the soft palate. So you have these 5 muscles: the tensor villi, levator villi, the uvula, palatoglossus, and palatopharyngeus. So the extent, the spread is almost going to be how we have seen the previous tonsillar spread, because the spread is basically through these muscles. So most common, it can go to the hard palate. It's a direct extent to the hard palate, and also to the tonsillar region. So these are the 2 muscles, palatoglossus and palatopharyngeal. So it can go to the tonsillar region, and deeper invasion to the other muscles, and it can take that tumor to the carotid space, skull base, and also can have a peridural extension along the V2, which in turn can have some cavernous sinus involvement. So these are the extent we are seeing. So how anterior posterior, this already we have seen. About a posterior pharyngeal wall, the extent, how it can extend is basically to the retropharyngeal space, and in turn to the prevertebral fascia, prevertebral muscles, and it can also go craniocaudally to the naso and the hypopharynx. About the lateral pharyngeal wall, so laterally these 2 muscles are related. So it's all I think the what same. So lateral pharyngeal wall also one get construct go to the parapharyngeal fat, and T1 sagittal section. It's a very good section to see many of these, especially to see the vallicula, pre-epiglottic space, and the base of tongue. So for these 3, we always prefer T1 sagittal. Why? Because the T1 has got it can highlight, because of the intrinsic fat content, the tumor can be very well seen. So because of the contents, what all possible is because the squamous cell carcinoma, lymphoma is possible because of the lot of lymphoid tissues, and some minor cellular tumors can come because of the presence of some cellular tissue. okay, so I will not go to the staging because they've extensively covered it. So what are the spreads are possible? One is through the constrictor muscle, one is through this pterygomandibular raphe and deep cervical fascia. It can also have a local infiltration. It can the adjacent structures can be involved rather than taking these easier routes. Adjacent structures can be involved, and then it can go to the other spaces. So submucosal spread to the nasohypopharynx. It can cross the midline and go, or it can go along the lingual neurovascular bundle. These are easier route. Floor of mouth, parapharyngeal space, along the styloid muscles. It can go to the hyoid bone, stylohyoid muscle. Whenever that we'll see just in the next slide. Then it can have a carotid space involvement. Then bigger tumors can go to the ITF masticated space involvement, perineural spread along V2, V3, and hypoglossal nervous common. Bone involvement, it can two areas to specifically look for, or this pterygoid hamulus, because of the attachment of these tensor muscle, the soft palate muscles, and another one is the central skull base near the because of the attachment of the raphe, where the superior constrictor muscle comes and attaches. So these two can act like a cord and take the tumor to the skull base. So two important areas to look for are the hamulus and the central skull base. So bone involvement, specifically in tonsillar cancer, look for the mandible, pterygomandibular raphe, where it is attached near the RMT region. That is more common to be involved. And for the floor of mouth muscle, look for the mandible and the hyoid bone because of the mylohyoid muscle attachment is there, because so the central arch near the where the muscle gets attached. So look for the mandible and hyoid bone involvement in floor of mouth. Posterior pharyngeal wall, vertebral involvements can be common because it is closer to it. And soft palate masses, look for hard palate erosion and skull base erosion. You can see, we have seen that how it can easily approach the skull base because of the muscles which have a craniocaudal orientation. So morphologically, how HPV positive and negative tumors can present in imaging. So usually positive tumors can present with exophytic and well-defined borders. It can have a bulky cystic appearing nodes. And the origin are mostly from the base of tongue and tonsil. Whereas in the HPV negative tumors, they usually have a ill-defined, very infiltrative kind of borders, and with the adjacent muscle invasion is quite common. So I'll show one case of so this is a HPV positive tonsillar tumor. You can see how there is a quite big mass in the left tonsillar region. So what we want to highlight here is the presence of this cystic nodes. You can see there are multiple enlarged left level 2B nodes are there. Some are conglomerate also. There is a uniform hypodensity within the node. So it could be a cystic node. So whenever there is a cystic node and when they're not, tumor is big but not so infiltrative, you have to think in terms of could be HPV positive tumors. So I think many were overlapped. So I try to cut short many of the slides. If there is anything I need to be touch again, so you can tell me now. I'm stopping my presentation with this. Bhagya?
Can you highlight on Priya? Can you highlight on the perineural invasion in oropharyngeal carcinoma? Which all areas you have to look?
Am I audible?
Yes, you are audible. For the sake of the residents, in which all situations you have to look for the perineural spread in oropharyngeal carcinoma?
Sorry, sir. I said. Sorry, sir.
Can you hear me? Perineural spread in oropharyngeal carcinoma.
Perineural spread in oropharyngeal carcinoma along the V2 nerve. How common it is, sir?
Yeah, no. And so I just want to. Can you just show them how to track that? Because if you have a lesion, the mandible is involved, then the inferior alveolar nerve involvement, then how to track that to the foramen ovale, or to, if you have a lesion involving the lesser palatine nerve along the pterygopalatine fossa, how to look
Yes,
that.
yes. Yeah. So pterygopalatine fossa, so normally you see a fat here. We have to be little careful that we are not interpreting. Sometimes the pterygoid plexus can come there, so it should not confuse that with that. So go craniocaudally and see whether it is actually continuing as a. So from the palatine canal, it is going to this is the pterygopalatine fossa, PPF. Between the posterior, this is the posterior wall of the maxillary sinus and this pterygoid process. With that, then the lateral opening, the medial end opens into the sphenopalatine foramen. This is the sphenopalatine foramen, and laterally it opens into the pterygomaxillary fissure. Where it opens, it's the pterygomaxillary fissure. Cranially, if you trace, sorry, I'm doing badly. Cranially, if you trace, it can go to the inferior orbital fissure. This is inferior orbital fissure, and then from there to have access into the middle cranial fossa. Okay, so this area, it will have access with the middle cranial fossa. So, and posteriorly, let me change the window. Yeah, posteriorly can show some widening or enhancement along the Vidian canal also. So where it can go to the posterior fossa of the brain also. So look for widening, look for enhancement. Widening and enhancement usually enhancement comes early, widening comes late. So that's why we prefer whenever perineural spread is suspected. We always prefer MRI, because in MRI what we are looking for is the enhancement. In CT what we are looking for is the widening, effacement or obliteration of this fat. Normally any foramen we can see some amount of fat will be there. So we look whether this fat is obliterated or it is replaced by some soft tissue. But these are you see with a little later stage. So to pick up early, even with the MRI, the sensitivity is only 70%. That's what literature says. So, and also look for skip lesions, because it need not to be continuous involvement throughout, like along entire course of the nerve. Sometimes there can be skip lesions also. So look for that. Anything else?
Thank you.
Can you show how the base of tongue tumor is extending lower down to larynx? How to look for the extension into the lingual surface of the epiglottis, and also to the pre-epiglottic space.
Okay. Here, yeah. So here it's more of a non-infiltrative kind of tumor. It is not extending towards the epiglottis. So look for whether this is the pre-epiglottic fat. Actually, he's having good amount of deglutition artifact. You can see the boards are looking double. That means some kind of deglutition artifact. So then I'll take to the normal side. So once the tumor is involved, so this is the vallicula, and this part is the pre-epiglottic fat. This part is the pre-epiglottic fat. So look for whether this fat is intact or it is obliterated by some soft tissue. So once that is involved, then look for next to the ariepiglottic folds. It can extend along that. So some predictable area of way of spread. So I think this is not a very ideal case to show he is having good amount of deglutition artifact, but look for thickening, whether there is any thickening of the ariepiglottic fold, and also replacement of that fat, which I showed in sagittal. Normally we see in sagittal the pre-epiglottic fat. So go to one end to the other end, because many times the corners can be means only we just see the midline and see, oh, it's not involved, but maybe when we go to the corners, we can see that maybe the pre-epiglottic space may be involved, fat may be involved. So this fat, this dark structure, this is the pre-epiglottic fat. Look for whether it is obliterated or intact. And then once it is intact, look for other the epiglottic fold, look for whether the hyoid bone is eroded.
Ma'am, there's a question for you on the YouTube chat. Shall I ask you the question?
Yeah. Please.
How to differentiate between cystic versus necrotic lymph nodes on CT?
Yeah, actually, both the density looks the same, agreed. Necrosis may not be very homogeneous. I mean to say homogeneous in the sense you may not see any solid component. Cystic nodes. So necrotic can have some amount of solid component, some amount of heterogeneity may be there. So cystic nodes, we see a homogeneous cystic kind of appearance. That's the way we go about it. Anything otherwise, the density wise, we cannot differentiate. Both look cystic density. Maybe necrosis will have slightly higher density, but that's slightly higher only when we have something to compare, we can say. So cystic will be more like the HU will be very less like a fluid. So necrosis, basically it is about heterogeneity and whether we see any amount of solid component associated with it or not. That's it.
Thank you very much, ma'am. Thank you for your
invite. Maybe the conglomeration also, because the what do you call it, the extracapsular extension, it's just the necrotic nodes may be more conglomerate nodes, cystic nodes may be more discrete nodes, they may not be conglomerate. So that is also true, that you can say that this is cystic, maybe this is necrotic. But the only area where you can tell for sure is whether if it is associated some amount of solid component is there or not. So if there is solid component, and it's more of a necrosis rather than cystic node.
Thank you very much, ma'am. Thank you for your enlightening talk on the radiological anatomy of HPV associated carcinoma. Thank you, ma'am. For our next session, I would like to invite Dr. Cecil T. Kainigal, Additional Professor, Department of Radiation Oncology, RCC Trivandrum, to talk on routes of spread and target volume delineation of the primary tumor in HPV-associated carcinoma oropharynx. Over to you, sir.
Can you hear me?
Yes, sir, you're audible.
Okay, thank you. So thank you, Priya, for the enlightening talk. So after Rajnisa's talk and the Dr. Malu, then Dr. Priya. So first, Dr. Sarbani, madam will join next. Okay, I will discuss about the routes of spread and the primary target volume delineation. The nodal delineation will be dealt by Dr. Lekha. We need to know that we all know that the subsites of oropharynx are one tonsil, second is soft palate with uvula, then you have the base of tongue, vallicular, posterior pharyngeal wall. This all constitute the oropharynx. So oropharynx is nothing but the pharynx behind the oral cavity. So if we take the one by one, how the tumor spread in each subsite. So Bhagya, please remind me after 25 minutes. Okay. Then so if you look into the tonsil, this is the palatine tonsil. Okay, you have the lingual tonsil, that is in the base of tongue. You have the palatine tonsil. How the tumor in the palatine tonsil spread. So this can spread anteriorly and inferiorly into the tongue, base of tongue, through the palatine. This is the anterior tonsillar pillar. The anterior tonsillar pillar is nothing but a fold which is covering the palatoglossus muscle. The palatoglossus muscle is an extrinsic muscle of the tongue, and the tumor in the tonsil can spread into the anterior tonsillar pillar, or the tumor in the anterior tonsillar pillar can spread here, and then it can gain access to the base of tongue. That's one route of spread. Second, it can spread from the tonsil or from the anterior tonsil. It can spread directly to retromolar trigon through a mucosal spread. This is another route of spread. Then posteriorly, it can spread to the posterior tonsillar pillar. Okay. Then laterally, the lateral to tonsil, you have the peritonsillar space. So this is the peritonsillar space. Lateral to the peritonsillar space, you have the muscle, which is a superior constrictor muscle. Dr. Priya was enlightening on the superior constrictor muscle. So once the tumor gain access to superior constrictor muscle, it can go into the origin and insertion of superior constrictor muscle. So that's why one of the reasons why we need to check whether superior extent of the tonsillar lesions to the origin and insertion of the superior constrictor. The tumor spreads more laterally. This is the parapharyngeal space. Lateral to the superior constrictor muscle, you have the parapharyngeal space. Then from the parapharyngeal space, it can it can enter into the masticator space. The masticator space, lower down, you have the medial pterygoid muscle and the mandible. Okay, if you have involvement of the medial pterygoid muscle, at this level, you are seeing the insertion of the medial pterygoid, which is inserted in the inner aspect of the mandible at the level of the angle of the mandible. So once the medial pterygoid is involved, then it becomes T4. And in P16 positive, it is no subclassification as Rajini sir told. So it is T4 disease and involvement of the mandible. So this is also T4. So between the medial pterygoid and the mandible, you have the mandibular foramen. So this is one of the area where the tumor can gain access to the neurovascular bundle. So that is the inferior alveolar nerve is involved. From there, it can go over or upwards to the foramen ovale. So this is one of the area where you can have a perineural spread. Posterolaterally, it can spread to the carotid sheath, then it becomes T4B. Posteriorly, it can spread to the prevertebral muscles. Once the prevertebral muscle is involved, then it doesn't change the staging, but this is the prevertebral muscle can occur. Then other thing you need to understand is that the superior constrictor muscle is interdigitate with the buccinator through a pterygomandibular raphe. So if you have a tumor in the superior constrictor, then from the pterygomandibular raphe, it can spread to retromolar trigon. So two ways by which the tonsillar lesion gain access to retromolar trigon. One by a mucosal spread. Second is through the pterygomandibular raphe. From the pterygomandibular raphe, it can go into the buccal mucosa. So what I have told you so far is one anterior tonsillar pillar, it can gain to base of tongue. You have posterior tonsillar pillar, that I will discuss later. Then superior constrictor, medial pterygoid. Then you have the inferior alveolar nerve. Then you have the mandible. So all this involvement of the masticator space at the level, it becomes T4 disease. Then if you look into the pterygomandibular raphe, this is very important to know the spread of a oropharyngeal carcinoma. So this is the level of the zygoma. Okay, one of the reasons why some of you may be still doing the 2D planning for the tonsillar lesion, then you can see that the superior border of the tonsil is at the level of the zygoma. Why it is so? Because one of the reasons is that you need to cover the entire superior constrictor muscle. The superior constrictor muscle arises from the pterygoid hamulus, one of the origin. Second origin is from the pterygomandibular raphe. Third origin is from the mandible, and fourth origin is from few fibers from the tongue. And it is attached to posteriorly. It is attached to the pharyngeal tubercle in the occipital bone posteriorly. So it goes up to the base of skull. That is one of the reasons why you treat up to the zygoma. Second reason is that in soft palate, it can gain access to the nasopharynx, lateral wall of nasopharynx, through the levator velar palatal muscle and tensor velar palatal muscle. Third reason you go up to the zygoma is to cover the retropharyngeal lymph nodes. So this is why you take up to the zygoma in a 2D planning in a tonsillar fossa lesions. So from there, once the tumor gain access to the superior constrictor, it can go into buccinator, because one of the posterior, origin of the buccinator is the anterior surface of the pterygomandibular raphe. That's the origin of the buccinator muscle. So that is why you need to know the superior constrictor muscle and pterygomandibular raphe. Posteriorly, it is attached to the pharyngeal tubercle and also in the medial raphe. So that is why you need to know this, how the tonsillar lesion can spread. So how you look in the MR, that already Dr. Priya has clearly mentioned, but I just want to highlight on this. Once you have the tumor in the palatine tonsil, it can spread into the anterior tonsillar pillar through the palatoglossal arch, which is nothing but the mucosal fold which is covering the palatoglossus muscle. Posteriorly, this is the palatopharyngeus muscle. Palatopharyngeus muscle goes down all the way down to thyroid cartilage. So if you have a tumor in the posterior tonsillar pillar, always you have to look radiologically whether the lesion is going into the posteriorly going down into the level of the thyroid cartilage. From there, so this is the palatopharyngeus muscle. we have already discussed the superior constrictor. This is nothing but the superior constrictor. I said the superior constrictor muscle is lateral to the tonsil. Then lateral to that, you have the what is nothing but the parapharyngeal space, which is hyperintense in MR and it is hypodense in CT scan. Lateral to that, you have the medial pterygoid muscle here. So if you have a tumor in the medial pterygoid, this becomes T4, mandible, it becomes T4. Okay, so that is the lateral spread I have already discussed. Posteriorly, you can have the carotid sheath. The prevertebral muscle involvement is not included in the staging of oropharyngeal carcinoma. Prevertebral muscle involvement in nasopharynx is T2. In larynx and hypopharynx, it is T4B, but it is not included in the staging of oropharyngeal carcinoma. The one another important thing you have to bear in mind in this cut is the posterior belly of the digastric, because that forms the anterior and the lateral boundary of the level 2 lymph node. Okay, so moving on to the soft palate, how the tumor spread in soft palate. So soft palate contains 5 muscles. One muscle, there are 3 origin and 2 insertion here. Okay, so the muscles which are originating from the palatine aponeurosis, which is nothing but this is the palatine aponeurosis, which is attached to the undersurface of the hard palate. And this is 2 muscles, that's the palatoglossus and palatopharyngeus we have already discussed, that originate from the palatine aponeurosis. The palatoglossus get attached to the extrinsic muscles of the tongue. Palatopharyngeus we will see in a minute. Then you have the musculus uvula originating from the palatine aponeurosis and it has no insertion. There are 2 muscles which is getting inserted into the palatine aponeurosis. One is the levator velae palatae muscle, and other is the tensor velae palatae muscle. The levator velae palatae muscle is more lateral, and tensor velae palatae muscle is more lateral, and levator velae palatae muscle is more medial. And this is closely associated with eustachian tube. So one of the origins of these 2 muscles, levator velae palatae muscle and tensor velae palatae muscle, is the auditory tube, and it is attached into the palatine aponeurosis. The tensor velae palatae muscle, which is lateral, which is hooking the pterygoid hammerless and getting inserted into the palatine aponeurosis. So we'll see from this, if you have a tumor in the tonsil, you can gain access to soft palate, to the anterior tonsillar pillar or posterior tonsillar pillar, or a primary in the soft palate can go upwards, and this acts as a fulcrum to gain access to the base of skull. Okay, I will show you that. So this is the inferior, this is the palatopharyngeus, which is getting attached to the upper border of the thyroid cartilage here. Okay, then you have the superior muscles, that levator velae palatae muscle and tensor velae palatae muscle. This is an axial cut cadaveric section at the level of the nasopharynx. In oropharynx, if you have a tumor which is gaining access to the fossa of Rosenmuller, which is nothing but the lateral pharyngeal recess here, this is the T4 disease, in P16 positive disease. The other is the T4 at the level of this level, we need to consider. One is the pterygoid plate destruction. Number 2, third is the lateral pterygoid muscle involvement. And the 4th is the carotid sheath involvement. If any of these are present in MR, then definitely you are dealing with an advanced disease. And the other important thing you have to bear in mind at this level is where you should look for retropharyngeal lymph node. If you have a tumor, if you have an enhancing lesion just medial to the internal carotid artery, either at the level of the nasopharynx or at the level of the oropharynx, you have to think that you are looking for a retropharyngeal lymph node. So now we will discuss the soft palate muscles, which I have deviated a little bit. This is the levator velae palatae muscle. Levator velae palatae muscle originate from the medial surface of the auditory tube. That's number 1. Second is the carotid sheath and also the undersurface of the apex of the petrous bone. So these are the 3 origins and getting inserted into the palatine aponeurosis. The second muscle is the tensor velae palatae muscle, which is more lateral. This is more lateral, which is originating one from the spine of the sphenoid. This is the foramen spinosum. So the bone which is attached to which is close to the foramen spinosum is called the spine of the sphenoid. So we are dealing with the lateral. This is the sphenoid bone. We are the greater wing of the sphenoid bone. So this is a spine of sphenoid. Then another origin is the scaphoid fossa. I will go back and I'll show you. This is the lateral pterygoid plate, medial pterygoid plate. This is the tensor velae palatae muscle. There is a fossa which is called scaphoid fossa, and this is a scaphoid fossa, and it is originating from that and also from the auditory tube lateral surface, and it is hooks around the pterygoid hammerless. This is the pterygoid hammerless, and it is getting attached to the palatine aponeurosis. Okay, how you look for the soft palate in a MR is that you look for the hard palate here. So if you are seeing nasal cavity, it is up, then the pharynx which you are seeing in nasopharynx. If you start seeing the hard palate, then the pharynx you are seeing behind the hard palate, it is the soft palate. The superior surface of the soft palate forms a superior boundary of oropharynx. So this is the hard palate is formed by two bones. One is the palatine process of the maxilla, and this is the perpendicular plate of the palatine bone. And posterior to that, you have the soft palate. So this is the soft palate. Okay, you have the superior constrictor muscle here. I'm not able to make out the levator velae palatae muscle and tensor velae palatae muscle at this level. To be very honest with you, and I can only make out that at the level of the nasopharynx, little up. Okay, so you look into this is at the level of the nasopharynx. This is a fossa of Rosenmuller. So if you have an oropharyngeal carcinoma gaining access to this level, it becomes T4. If it is P16 positive, this is nothing but the levator velae palatae muscle, which is originating from the carotid sheath and also from the medial surface of the auditory tube and also from the undersurface of the petrous, the apex of the petrous bone. Second is the tensor velae palatae muscle. This is the tensor velae palatae muscle. You cannot make out the medial pterygoid because it is at a higher level. You can only say the origin here. This is the bulk is formed by at this level is the lateral pterygoid muscle here. Coming to the superior and inferior extent, you have the this we have already discussed, the superior surface of the soft palate. Dr. Priya has clearly mentioned that. Inferiorly, it is at the level of the pharyngoepiglottic fold. And same this, Dr. Priya has shown this picture. I will show you a few from what we have gathered to what we have learned together. So here, if you look into this is a homogeneous enhancing lesion on the left lateral pharyngeal wall. It is abutting the base of tongue. Compared to the right side, you can say anterolaterally, you can see the lesion is extending into the retromolar trigon. You can make out the right medial pterygoid here, but it is very clearly, you can make out that. You cannot make out the medial pterygoid on the left side. So this probably infiltrated. And you can see the abutting of the prevertebral muscle, but there is no infiltration. Lesion is crossing the midline. And also you have a retropharyngeal lymph node. The tumor in this cut seems to be infiltrating the carotid sheath. So it is a T4 disease because of one, it is because of the carotid sheath involvement, medial pterygoid muscle involvement. And the retromolar trigon involvement is more clear here. This is mainly because of the pterygomandibular raphe involvement. It is again going down to the level of the base of tongue. You can see that. And you can see the bilateral nodes. It is a T4 N2 disease if it is P16 positive. And then this becomes a stage 3 disease because of T4 disease. T4 or N3 is stage 3 disease. Again, a similar picture you can see at the level of the fossa of Rosenmuller. So it is a T4 disease. You can make out a retropharyngeal node. Again, it is a T4 N1 disease. Here, this is another MR which shows a retromolar trigon involvement. Okay, so you can see that. You can see the left buccinator here, but the right buccinator is enhancing in the posterior aspect and also retromolar trigon. You can see the medial pterygoid is intact on left side, lesion involving the soft palate and also the tonsil, and the lesion is infiltrating the medial pterygoid muscle. I'm not sure with this whether it is infiltration from this cut alone, maybe a nubber, but we have to look into the other cuts. How to look for the coronal view, that's also very important because you can make out the superior and inferior extent in the coronal view also. This is at the level of the nasopharynx, but this you can make out, this is at the level of the oropharynx, soft palate. And you can see this is a pharyngeal mucosa. Then just lateral to that, you have what is, I've told you that superior constrictor. The muscles are iso-intense or grayish. So this is the superior constrictor muscle. More lateral to the superior constrictor, you have the parapharyngeal space. This is a medial pterygoid, which forms the main bulk of the mastigator space. This is a lateral pterygoid muscle here. And you have the masseter here. This is a mandible. And this forms the mastigator space involvement. So if you have a tumor involving the medial pterygoid and more laterally, then you have the inferior alveolar nerve here. You have to think about there is a perineural spread in oropharyngeal carcinoma. It is very low compared to the oral cavity, but you have to think that. Then you have to think whether there is any enhancement between the mandible and the medial pterygoid, and then between the medial pterygoid and lateral pterygoid, and then from lateral pterygoid and tensor velae palatae muscle, and it gain access all the way up to foramen ovale. Again, you can see that this is up to the nasopharynx. You can see and the posterior pharyngeal wall involvement. And this is an advanced disease. It's a T4 because of the nasopharynx involvement. Coming to the contouring guidelines, first I will take the tonsil. This is the international guidelines published in Green Journal. And Dr. Sarbani Madam is also an author of this international guidelines. And second is the nodal oleum delineation. Last update came in 2019. Dr. Lekha will discuss about the nodal, and I will discuss about the primary tumor. And if this is the international guideline is based on 4 principles. One is the adaptation of the air cavity. Second is you have to take care of the complex head and neck anatomy. And third, there is a strong belief that the anatomical barriers can prevent the tumor cells from free diffusion. And the fourth component is the experience gained from the surgical data. So it is a fine balance in composing the tumor oleum, and at the same time, you avoid excess toxicity from radiation. So if you have always, we should have a checklist before contouring. That is very important. So if you are planning to contour, always we should have a checklist. Clinical and radiological. You have to correlate. So you have a tumor. So here you can see that you have a tonsillar lesion. So anterior tonsillar pillar here, posterior tonsillar pillar. You have to document the lesion is extending in the soft palate. Posterior tonsillar pillar is involved. Posterior pharyngeal wall is involved. Retromolar trigone is involved. Base of tongue is involved or not. Then what about the floor of mouth, anterior two-thirds of the tongue? And then you have to look whether in the clinically it is coming to retromolar trigone, definitely whether a mandible involvement, what about the medial pterygoid involvement? These all need to have a clinical and radiological correlation. So you can see there's an enhancing lesion, a homogeneously enhancing, well-enhancing lesion in the left tonsil. So before contouring, you should have a clinical and a radiological checklist. This is very important. What I have given in red is the clinical, and this is we cannot make out only by radiological. So here should have a base of tongue plus bar minus, retromolar trigone plus bar minus, soft palate plus bar minus, anterior tonsillar, anterior tongue plus bar minus, floor of mouth. This should be clinical. And before contouring any patient, this should be properly written and discussed. And you have to look into the medial pterygoid, mandible, buccinator, carotid sheath, posterior pharyngeal wall before contouring. So there should be a proper checklist with clinical examination and radiology. I will take few examples. One, I will take what the international guidelines say. Then I will take few cases we have done. One is this is the tonsil, left tonsil, and this is in the T2 disease. You can see the lesions just extending into the anterior, so base of tongue, but there is a definite demarcation is there. Mainly lesion is in the anterior tonsillar pillar and tonsillar fossa. Up to the posterior tonsillar pillar, posterior pharyngeal wall seems to be free. So in this tumor, what the international guideline is done is what you see in clinical examination, that is very important. Sometimes the mucosal spread, very subtle mucosal spread in the uvula or in the soft palate can be seen only in clinical examination. That may be missed even in MR. So we have to look that clinically, then you have to include that. Especially if you have, I insist my senior resident to have a photograph of earlier lesions. Then you look that before do simulation. So this is the GTV. Then the GTV plus 5 mm is your CTV-P1, and you have another 5 mm that is called CTV-P2. So there are GTV, CTV-P1, and CTV-P2. That's oleums in the primary target oleum delineation. So this is the GTV. You have 5 mm, that is CTV-P1. Then you have another 5 mm, that's CTV-P2. So if you look into the French guidelines, you have the Dahenga guidelines, you have the international guidelines. There's a slight difference between all these three, but if you go into the Dahenga guidelines, you see 5 mm geometric expansion. But in the international guidelines, what they have done is that in CTV-P1, they have excluded from the posterior pharyngeal wall because that's free and it's going to act as a barrier. And second is the air cavity. And third, in the CTV-P2, they have edited from the medial pterygoid muscle. So in the CTV-P2, medial pterygoid edited, then the prevertebral muscle is not included, and also the air cavity. So the final will be the green one. So this will be the CTV-P2. So this is in the sagittal, in the coronal view. you can see that it has been edited. This is a medial pterygoid muscle. It has been edited from the medial pterygoid muscle. So believing that beyond the parapharyngeal space, it is unlikely to enter into the medial pterygoid muscle. Then I will take few examples what we have done. So this is you can see compared to the left tonsil, you can see a lesion in the right tonsillar area. And it is also, if you look carefully, it is actually these infiltrating the medial pterygoid muscle. It is T4. The anterior tonsillar pillar is involved, and it is the posterior tonsillar pillar is also involved. But you cannot clearly make out whether soft palate is involved. Seems to be free. Then in the second cut, whether we have to think about this is actually it is infiltrating the base of tongue. So this is if you look into the GTV, if I contour the GTV, then this will be my GTV. So it include a part of the base of tongue because that's infiltrated there. So that is very important. And always you should palpate in such situations whether the posterior, 1/3 of the posterior or base of tongue is involved or not. You have a proper clinical examination before contouring. So once when we do a GTV delineation, you can see that. So this is my GTV. So that is the GTV. Then if you have another 5 mm cut, I have not edited from the airway cavity. So this is, but I have edited from the mandible. Okay, so this is the CTV P1, you have 5 mm margin, and you have a CTV P2, I have edited from the mandible. So this is the CTV P2. So that is the CTV P1 and CTV P2 for that cut. And if you look into the next cut, you can see that the lesion is just extending into the base of tongue. So this will be my GTV. So this will be my GTV. Okay. Then you have another 5 mm. So that is your CTV P1. Then you have another 5 mm expansion. That is your CTV P2. The next cut, that's again, if you look here, it is your GTV. So this, you can see that if you look into this CT scan, you can see that the parapharyngeal fat on the right side is obliterated compared to the left, and the lesion is infiltrating into the base of tongue. But the medial pterygoid, this is the last cut of the insertion of the medial pterygoid, it seems to be free. Again, this is the CTV expansions. The CTV P1, again, you give 5 mm margin. This is your CTV P2. So this is the CTV P1 and P2. And if you look into the coronal view, you can see that the parapharyngeal fat is free, but there's a minimal extension into the soft palate, minimal extension. You can see that. So this is your GTV. Again, you have 5 mm, and this is CTV P2. But if you look into the international guidelines, you can say that the volume will be a little less because there will be editing from the medial pterygoid muscle. But I have included the medial pterygoid muscle also, part of that is included. Now another area, again, you have an MRI which is showing this is at the level of the fossa of Rosenmuller. You can see that the nasopharynx, lateral wall of nasopharynx involved. So it becomes T4. It is a P16 positive tumor. Then this is slightly diffuse. It's difficult to make out the anterior extent. You have to look into the other cuts as well. Here, slight extension medially, which is crossing to the opposite side. The posterior pharyngeal wall is involved in all the cuts. Medial pterygoid seems to be intact. The retromolar trigone area is free. There is no, the retromolar trigone is free. There is abutting of the prevertebral muscles. You can see that the parapharyngeal fat is obliterated on the right side in this cut. And so this is the CTV at 3 levels. And you take CT scans, you can see that this is not a good CT scan. The contrast is not that good. Sorry for that. So, but you can see that this is the tumor coming up to the midline. Here, I find it very difficult. I seek Priya. I will send my SR to Priya before contouring this. Priya, whether this is tumor. So I feel that it is crossing to the opposite side. So this is the GTV here. It is more clear here. This is a GTV. So just coming into the midline. Okay. So if you could do that, so this is your GTV, you have another 5 mm, that's your CTV P1, then your CTV P2. I have edited from the clivus, edited from the pterygoid plates, from the mandible, and but I'm treating the parapharyngeal space, and a part of the medial pterygoid also will receive 70-degree equivalent dose. This is the coronal and the sagittal view of the same patient. Now coming to the second part. Bhagi, I have another 5 minutes, 10 minutes.
Yes, sir.
Yeah. So coming to the base of tongue, so if you look into the roots of spread, you can see that the base of tongue tumor, inferiorly, it goes into the larynx. So this is a ligament is there. This is the hyoid and this is the epiglottis. There is a ligament which is called the hyoepiglottic ligament, okay, which forms the superior surface of the pre-epiglottic space. But once that is breached, it can gain access to the pre-epiglottic space. And Dr. Priya was showing that. So that is the inferior extent of the extension of the base of tongue tumors. The lesion can involve the lingual surface of the epiglottis, that is only T3, and that is irrespective of the size of the tumor. If you have a lesion in the vallecula or base of tongue, 2.5 into 2.5, but it is extending into lingual surface of the epiglottis, it is T3, irrespective of the size. Then from the base of tongue, it can gain into the floor of mouth. Always you should properly palpate the floor of mouth and see if there is, especially if you have a primary in the base of tongue, lesion can gain access to the extrinsic muscles of the tongue. This is very important. If you have a small, you may think it is a T2 disease, but once the lesion from the base of tongue is infiltrating the extrinsic muscles of the tongue, it becomes T4. Okay, because then you need to add chemotherapy. You will be upstage the disease. Okay, that's very important. Superiorly, it can go in from the base of tongue, it can go into the palate, into this tonsil through the anterior tonsillar pillar. We have discussed that. Then from there, it can go into the soft palate. Okay, that is important. Posteriorly, if you have a tumor, it can spread into the parapharyngeal space. Then it can gain access to carotid sheath, posterior pharyngeal wall. Laterally, it can go into the pterygomandibular raphe. Okay, so this is MR. This is very important. So this area is the base of tongue. Okay, if you have a tumor, this is the genioglossus muscle. This is the lingual septum. So if you have a tumor, it is extending into the extrinsic muscles, genioglossus muscle, then it becomes T4. If it is HPV negative, it becomes T4A. And then you have, this is the hyoglossus muscle. Okay, you have a hyoglossus muscle. This is the genioglossus muscle. These are the two extrinsic muscles you can make out in MR. The other muscles, the small muscles may not be able to make out. The other thing you have to bear in mind, whether the floor of mouth is involved. That's also very important. How you look for floor of mouth is that whether the mylohyoid is involved. How you look for mylohyoid? This is the mylohyoid. Mylohyoid arises in the mylohyoid ridge in the mandible, and it is getting attached to the hyoid bone. That is the mylohyoid. So this is a mylohyoid here. Then between the hyoglossus and mylohyoid, then you have another space that is called the sublingual space. If you have a tumor at the base of tongue, it gains access to the anterior two-thirds of the tongue. It can even involve the sublingual space. How you distinguish sublingual space from submandibular space? It is by the mylohyoid. Okay, I will tell you how to do that. So this is the submandibular space. The mandible, the space which is just medial to just inner to the mandible, that is the submandibular space. It is hyperindense on MR and hypodense on CT. And between the submandibular space and sublingual space is the mylohyoid muscle. Mylohyoid muscle separate the submandibular space with the sublingual space. So this is how you look for the mylohyoid. Okay, so that is very important. Now you look for the vallecula. So you have the base of tongue, then you have the vallecula. Vallecula lies between the tongue. Okay, some say it is the root of the tongue, Dr. Priya said, but we believe it is the base of tongue. Then in the posterior aspect of the base of tongue, then this is the epiglottis. Epiglottis have the lingual surface and the laryngeal surface. Then between this, between the base of tongue and the lingual surface of the epiglottis, you have the vallecula. So vallecula on either side is divided by a median glossoepiglottic fold. Okay, and laterally it is the pharyngoepiglottic fold. This is the pharyngoepiglottic fold. This is the pharyngoepiglottic fold, and this is the lateral boundary of the vallecula. And the lateral pharyngeal, this is the lateral glossoepiglottic fold, which is also called the pharyngoepiglottic fold. This is the inferior boundary of oropharynx. Anything below that, that is considered as a laryngopharynx. Okay, so this is the between, I said between the base of tongue and the lingual surface of the epiglottis, you have the vallecula. This is the vallecula. So from the tumor, we can gain access to the pre-epiglottic space. This is the pre-epiglottic space. This is the pre-epiglottic space. This pre-epiglottic space this is this space. This is the hypodense area, is the pre-epiglottic space. This is a median glossoepiglottic fold, which you see on CT scan. On either side, you have the vallecula. This is a pharyngoepiglottic fold. Okay. How it looked in MR is, this is a median glossoepiglottic fold. This is a vallecula, and this is the epiglottis. You have the lateral. This is the lateral glossoepiglottic fold or pharyngoepiglottic fold. Now we will look into few cases. This is a base of tongue. You can see a lesion in the base of tongue. It is involving the base of tongue and also into the vallecula. You cannot make out that. Then it is extending into the pre-epiglottic space. You can see the hyperindense area in the pre-epiglottic space, and also in the laryngeal, you can see the epiglottis, and this becomes T4A in HPV negative and T4 in the P16 positive disease, because oropharynx extending into larynx. So if you are in the base of tongue, T4 is constituted by 1, the involvement of the extrinsic muscles and also involvement of the larynx. If you have a tonsil, we discussed the T4 is constituted by medial pterygoid muscle, then the lesion involving the mandible. This is important. If you have a prevertebral muscle involvement, no change in the staging. Carotid artery encasement, it is T4B in P16 negative, or it is T4 in P16 positive disease. Other areas you look, I already discussed, that is the lateral pterygoid plate. Okay, this is T4, and the patient is T4, and the patient has this patient has a node here at the level of the level 2. So it is T4N1, P16 positive disease, stage 3 disease. So T3 is more than 4 centimeter or lingual surface of the epiglottis. T4 is larynx, is involvement or extrinsic muscle from base of tongue. So this is again, before contouring in a base of tongue tumor, you should have a checklist whether extrinsic muscles of tongue is involved, whether you have a floor of mouth involvement, a larynx involvement is there, whether the base of tongue, from the base of tongue, the lesion is extending into the tonsil, anterior tonsillar pillar, tonsil, whether the posterior pharyngeal wall is involved. Then you should have the lesion involving the medial pterygoid muscle, and also we know that the base of tongue and soft palate is rich in lymphatics always, and there is a chance for a bilateral lymph node. Always you should look for that. Okay, Dr. Lekha will discuss that. Now, if you have this is again from the international guidelines, the lesion is involved in the lingual surface of the epiglottis, so it is a T3 disease. Size-wise, it is not more than 4 centimeter. And what we have done is, this is the GTV. Then you give another 5 mm margin, that's your CTV P1. Then another 5 mm, that is CTV P2. And it is like it's edited from the prevertebral muscles here and also from air cavity. And always a part of the pre-epiglottic space will be included in the treatment of the in the CTV P2 of the base of tongue. Generally, you need not take the hyoid in the CTV P1, but when you give 5 mm expansion, it will be outside the hyoid bone in the CTV P2. So I will take one case. So this is an MR which showing a lesion involving the base of tongue. Here you have to look again whether genioglossus muscle, this MR is not that of good quality. You have to look that whether it is involving that. So I feel that this is likely to be involved because it's of irregular outline. You can see that this likely it's a T4A disease or T4 disease because of the extrinsic muscle involvement. Again, I have to look into the other cuts in the axial cut also. So if after the CT simulation, you have to, this is the genioglossus here on the left side, you can very clearly make out the genioglossus. This is the lingual septum, which is hypodense, and you have the hyoglossus muscle here. So if you look into the GTV, you can see that this will be my GTV. Okay. And here, I'm not sure whether the posterior tonsillar pillar is, posterior area is involved, but compared to this side, there is a thickening is there. So I will take up to this. Okay, I'm not sure. Maybe you are right if you stop the GTV contouring here. Okay, so but I've taken up to this suspicious area because of the thickening on compared to the left side and minimal enhancement compared to the right side. So this is my GTV. Then you have to give another 5 mm margin. So that will include, that will extend into the oral cavity. That is extend into the oral cavity, the oral tongue. So, and again, when you give the PT, then again, if you include that into CTV P1, so this is CTV P1, then you give another 5 mm margins. This is CTV P2. I've edited from the mandible and not from the air cavity. So this is my final CTV P2. And if you look into the distribution, we use a 66 grain 30, that's a SIPT protocol, 60 grain 30 for CTV-P2. So this is a 66 grain 30. So this is the GTV covering that area. So this is the 6468, that's a 98% of the CTV. That's the prescribed dose. So 98% of the dose should cover the 100% of the CTV-P1. So this is the 6468 centigrade. Then you have the CTV-P2. This patient had a level 2 node down. So that node is not seen here, but we have bilateral nodes were there. So the level 2 was given 60 gray. So this is my GTV. This is my CTV-P1. It's my CTV-P2. And this is the nodal, this one. So if you take the 58.5880 centigrade, that's 98% of the 60. So this will be the dose distribution. Yeah. Yes, I have another 5 minutes, Bhagya.
Sir, time is still 7:10.
7:10. So can I take another 5 more minutes?
Yes, sir.
Okay, fine. So if this is another case, I think this is the last case. Okay, so this is a base of tongue. You can see the lesion there, and it's also involving the vallecula and also the pedungulated lesion. You can see that. Okay, so this is my GTV here. Then you have another 5 mm. So that's the CTV-P1. This is the CTV-P2. Then the distribution. This is CTV-P1 and no, that's also CTV-66. So that will be the CTV-N1, CTV-P1 and the CTV-N1. The 2 nodes, bilateral nodes are there. So this was given the 98%. So this is the 6468 of this one. And this is a PTV. So this is GTV. This is CTV-P1. Then you have the PTV of this CTV-P1. So that's a PTV. Then you have encompassed the whole thing. That is the 98%. That is this 6270 of the 66 gray. So this, and again spillage because this is because of the nodes were there. So that's 6270. Again, this is 60. You can see that this is the GTV. Then you have CTV-P1. This is CTV-P2. Then you have the nodes on bilateral side. That is also given 60 gray. So that's a 588. So this is the 58.8. That's the 98% of the 60 gray. So coming to the conclusions. So clinical examination is the key. So you should have a proper, especially if you have a base of tongue tumor, you have a tonsillar lesion, you have a soft palate, you have to properly palpate the tumor. Then from the clinical examination, you make a checklist, plus bar minus. Then always you should look for potential areas of spread clinically as well as radiologically. This is very important. Always you should make a checklist for each subsite. Then try to learn the head and neck radiology by yourself and correlate the clinical and radiological findings. If there is any disparity, if you have any issues in assessing with the medial extent and anterior extent, always you should discuss with the radiologist. We have a very good dedicated head and neck radiology team. Definitely they always, when we always go and discuss with them. They have only taught us the radiology. And always you should try to discuss with them and then you condo. And the proper interaction is very important. So this is one of our chapter contributions. So because this is the human papilloma virus oropharyngeal carcinoma, I thought this. If you are interested, you can search in the Google this, and my junior colleague Dr. Aparna has written this chapter. So this is you can go through that. And I have an announcement. So this is Aroy Estro course. Sarbani Madam is the Aroy, the course director. And we are this last time the Tata Memorial Hospital hosted the first the Aroy Estro teaching course, and this time it is going to be in Chennai. The Secretary General of RI, the Dr. Srinivasan, is hosting the meeting in Mayo Hospital, and we have the faculty from the India as well as from the Europe. And by God's grace, I'm also a faculty for the same teacher for the course. So please register for this course if you have any. This will be very useful. This time we are discussing the oropharynx and nasopharynx. Always the radiology and the contouring, and there will be homework for you. You can go through that, and this will be very useful for you. So thank you very much for your patient listening. Okay, over to you, Bhagya and Livia.
Thank you, sir. So we have a question in the chat box.
Yes,
In
please.
case of induction chemotherapy, do we consider the residual disease or pre-chemo GTV while target volume delineation?
Okay. So if you look into the pre-chemo, whether we can reduce the volume after induction chemo, that's a real concern. If you look into the data for nasopharynx, that's really promising. But apart from nasopharyngeal carcinoma, we don't have a clear data to say that we can reduce the pre-chemo volume. So my suggestion will be the pre-chemo volume will be your GTV, then pre-chemo volume plus 5 mm will be your CTV-P1. Okay, yes.
So that's about the questions. Thank you for this very detailed session on the route of spread and nuances of target volume delineation primary CA oropharynx. Next, we have the much awaited session on evidence of TORS in HPV positive CA oropharynx by Dr. Sharbani Ghosh-Leskar. She's a professor and chief of head and neck radiation oncology at Tata Memorial Hospital, Mumbai. Over to you, madam.
Good evening, everybody, and thank you very much, Rajneesh and Cecil and his entire team for this invitation. I'll just share my screen. Good evening, everybody. I hope you can see my screen and slides.
Yes, ma'am.
Yeah. Thank you very much. So what I will be talking about to you right now is essentially how we can integrate the newer modalities of surgery into the treatment of HPV positive oropharyngeal cancers. We've had some excellent talks through the evening, which have dwelt on the staging, the radiology, the routes of spread, as well as the de-escalation strategies that have been used in the management of HPV positive oropharyngeal cancers. I'd like to start off by saying that most of what I'm going to talk about is essentially a reflection of my opinion based on available evidence. And I've also taken recourse to one very good review article that was published way back in 2016. And though it's been 7 years since, I think it is a very excellent point of reference, because even today we continue to treat oropharyngeal cancers, and TORS as it stands today has to be integrated with what is the accepted modality for treatment. I have no conflicts of interest. So pre-TORS era or pre-HPV era, what we had was non-operative management was the usually preferred approach for the management of oropharyngeal cancers. There have been advances in combining systemic therapy and radiation technology. And of course, this was associated with improved survival and lower use of surgery. Now, for early stage cancers, that is essentially the node negative T1, T2 cancers, the treatment was usually single modality treatment, radiotherapy alone, which could be either external beam radiotherapy or external beam radiotherapy with a brachytherapy boost. And surgery was usually done and reserved for very select cases. Now, the rationale of doing this was essentially that single modality treatment yielded good control. Radiotherapy or surgery had equal outcomes in various sites and almost 85 to 90% local control at 5 years. The choice was based on the subsite involved, the patient's preference, institutional practice, and complexity of the procedure and the expertise that was available. Now, what are the benefits of radiotherapy over surgery? Superior functional and cosmetic outcomes, risk of a major post-operative complication, as we keep hearing, is avoided. Elective neck can be treated, especially when we are doing radical radiotherapy itself or radical radiotherapy in combination with chemotherapy, with little added morbidity. And surgical salvage of radiotherapy failure is probably more likely than the salvage of a surgical failure. What about advanced stage disease? Multimodality therapy has been the norm. concurrent chemoradiotherapy using platinum-based regimes, concurrent chemoradiotherapy with cetuximab. Altered fractionation schedules have also been tried out. And of course, it is hyperfractionation over any other form of altered fractionation without an accelerated fractionation. If it has to be used, it should be without a reduction in the total dose. And of course, in some cases, again, pre-HPV and pre-TORS, surgery with adjuvant RT alone or CT-RT when indicated. Then, so thus far what we knew was that single modality treatment for early stage cancer, radiotherapy was preferred over surgery. Combined modality treatment was for advanced stage tumor and good control rates with acceptable toxicities. And this was essentially a function of the T stage, RT dose and volumes of radiotherapy. But what we have to remember, whatever said and done, the radiotherapy technique in those days was essentially conventional or at the most 2.5D and with the antecedent high toxicity of multimodality protocols. And of course, when it came to surgery, it was mostly open surgical approaches with flaps. But things changed. What happened was that we had the advent of minimally invasive surgery, either TORS, that is transoral robotic surgery, or transoral laser surgery, recognition of the toxicity of CT-RT. We had IMRT coming in, and then later on, of course, IMRT with IGRT with the ability to improve the therapeutic ratio. And then, of course, recently in the last 2 decades, it has been the higher incidence of HPV-related cancers, especially in the West, first in North America, and then soon to be followed by European countries. So what happened with the HPV positive head neck cancers? I won't go too much into details because we've already heard this from Rajneesh as well as from Mala. That the major shift in the epidemiology, what we saw was as the incidence of other cancers was decreasing, there was an increase in the incidence of oropharyngeal cancers, and most of these were associated with HPV positive infections. So the paradigm shifts were essentially organ and function conservation, aggressive multimodality protocols, and of course, because of the realization that HPV positive cancers behave differently, we had to pay attention to the quality of life and patient-related outcomes. But what was the bottom line was uncompromised disease outcomes with reduced morbidity. So what we do know that there was almost a 3-fold increase in the proportion of HPV positive cancers in the US. However, we do know that the prevalence in India is low, but it is rising because recent reports talk almost about a 40% incidence in some areas. And the trend of head neck squamous carcinomas in the developed nations was that the percentage contribution of oropharyngeal cancers towards the head and neck cancers, of course, increased. And this was almost to the tune of 16% way back in 2011. And of course, this is a table that we've already seen with Rajneesh as well as Mala. And I won't tell you anything except to state that when we had this initial report, what we found from this systematic review and meta-analysis was that HPV positive cancers are different. They behave differently, but have better outcomes. And based on this, was there a need to alter treatment? Maybe no, maybe yes. Why no? Because perhaps we had achieved the best survival in these group of patients. Rigorously, it was needed to evaluate new prognostic factors, and there was lack of prospective events at that time about the and there was a paucity of trials looking at oropharynx alone. But yes, possibly because altered fractionation in radiation therapy alone had shown to improve locoregional controls with small impact on survival, increased acute and late toxicity burden. So we definitely knew these patients were doing better, they were living longer, they were younger, so definitely we needed to do something for them. Then there were newer approaches that were available, as I said, because of IMRT, targeted therapies, TORS. And of course, we had to then look at optimal combination of therapies for equivalent outcomes. We also have this paper from Andy Trotty, which clearly showed that as we went on in our attempt to improve outcomes and combine treatments, the toxicities went much higher. And what emerged at the best or the most intensive and the most curative form of treatment, that is a combination of platinum-based chemoradiotherapy, was possibly most toxic also. And long-term morbidities of full-dose chemoradiation if you look at them, they included swallowing dysfunction, pharyngeal strictures, xerostomia, chronic pain, subcutaneous fibrosis, in some cases osteoradionecrosis, and these were relative because, as I said, these HPV positive tumors were younger, lived longer, had better outcomes. So we had to definitely think of a different course of action. So then emerged the role of surgery. In the HPV positive patient, TORS represents a modality for treatment de-escalation, which means what? Perhaps you do surgery, you need to do nothing else in the well-selected cases. But what would be the target population then? T1N0 and T2N0 oropharyngeal cancers. But we have to remember that when we do this, that the oropharyngeal cancer group is not one single uniform group. Not only as far as the risk stratification is concerned, but also with regards to the clinical outcomes. They are a heterogeneous group. And of course, oropharyngeal cancers could either be HPV positive or HPV negative. And today we are talking about the HPV positive cancers. The greatest use of surgery, therefore, in these HPV positive cancers, if you are looking at it as a means to reducing the toxicity, would be when it could be used as a single modality. There is no contention there. And we are really not arguing about it. But what today we're going to talk about is how can we integrate surgery into our other scheme of things so that we can give the best outcomes as well as control the morbidity. These techniques allow for excellent functional outcomes with minimal postoperative morbidity. The oncologic efficacy of TORS is clear, and for select patients, functional outcomes are outstanding. The greatest advantage of TORS HPV-related oropharyngeal cancers is as a method of de-escalation, as I've already said. So what could you do? Avoid RT and its sequelae, reduce the dose of adjuvant RT, maintain quality of life, and perhaps reduce the tube dependency. So now if you look at TORS versus radiotherapy, immediate versus protracted treatment, accurate prognostic information, which may help to tailor treatment thereafter. Cytoreduction will reduce hypoxia-induced tumor resistance, sparing of swallowing apparatus in the suitably selected cases, sparing the acute and troublesome late toxicities of radiotherapy. So if you have this paper from Virginie Axiom, what it really tells you about is actually that the long-term functional and quality of life outcomes with TORS are much better if you do TORS alone versus if you were to do TORS plus radiotherapy. So what you have to understand is the benefit of TORS lies in its use as a single modality treatment and not if it is a part of tri-modality treatment, because there you would also increase the amount of radiotherapy that you had to give as well as the radiotherapy related sequelae. So patients who underwent TORS plus CTRT demonstrated poorer long-term outcomes with continued dysphagia more than 1 year after surgery, and these findings support the investigation of adjuvant de-escalation therapies to reduce the long-term adverse effects of treatment. So if you use this as the platform, then let's come to the important issues. So what all these studies have highlighted is that what is most important to having optimal outcomes is preoperative selection of patients, and also to kind of address the controversies that lie in the use of adjuvant management of both early and locally advanced cancers. The other thing is it is especially useful if you can decouple the treatment of the primary from the treatment of the regional nodes. And also, if you could be very sure about the laterality of the tumor, then that could also be useful in trying to reduce the doses to the opposite or contralateral neck. That means you could understand the laterality of the tumor and use it as a means to reduce the volumes and the doses of radiotherapy that you're going to give to the uninvolved areas. So let's look at this particular paper, which actually talks about for early stage disease, which are the patients that should be suitable for TORS. Patients' comorbidities. So if you have patients who are active smokers, unwilling to give up smoking, and then they want to undergo treatment for their oropharyngeal cancer, which is HPV positive, perhaps TORS may be the way to go. Patients who live a great distance cannot stay back for the entire course of treatment. There again, TORS would be good because it would be a single sitting treatment. prior history of radiotherapy to the face and neck, obviously we always look at surgery as the first course of treatment in the ones that are resectable. Patients with poor social support, especially who are at risk for non-compliance. Who are the patients for radiotherapy? Those with tonsil cancer and medial internal carotid artery that portends an increased risk of post-operating bleeding. And this is where I will allude to the orator trials. If you looked at the orator 2, the major two reasons, the two deaths that happened was essentially because of bleeding. And this could be one of those reasons. And hence, if you see this on the MRI or the staging investigation, you would preferably treat this patient with radiotherapy rather than with TORS. Patients requiring anticoagulation, because of course, though you know you're treating younger patients, you may also have those older patients who require anticoagulation and are at high risk of medical events upon cessation of use of these agents, and patients for whom exposure is a concern, like people. So you do not want patients who have to be off any form of therapy for long. So in those patients, again, radiotherapy may be the treatment of choice. For early stage disease, the disease-related indications for TORS are, of course, the small T1, T2 tumors, which are exophatic with minimum invasion into the surrounding muscular and are likely to be resected with negative margins, which means that you will not perhaps have to use adjuvant therapy. Patients with cervical adenopathy, which are considered to be borderline on PET-CT, that means you think it could be with ENE or without ENE, because again, there may be upstaging in almost 30 to 40% of the patients, or they may be downstaging in about a third of those patients. So there it may be useful, because then TORS would be a means to actually prognosticate, as well as your histopathology would help guide the adjuvant treatment. When do you not use? When you have larger tumors with significant muscular infiltration. These patients are likely to require adjuvant RT and sometimes adjuvant CTRT. Then you will not take these patients up for TORS. Patients who may require a free flap or similar reconstruction post-operatively. Again, if these are the patients, you may require to then do adjuvant therapy. Uncommon primaries of the posterior oropharyngeal wall, given the concern for muscular invasion, narrower surgical margins, and inferior outcomes. Again, this thing against TORS is essentially where you would have to give adjuvant therapy or adjuvant chemoradiotherapy after the procedure of TORS. Now, what about advanced stage disease? It may benefit the loco-regionally advanced population through pathological downstaging, as I've already mentioned. In unknown primary cases that are HPV positive of the lymph node, it may be useful to use TORS just as to do the palatine and lingual tonsillectomy and use radiotherapy for the neck node. Now, this is essentially a guideline given by the ASCO, but we have to temper it a little when we're using it in our population. And TORS may be a method of de-escalation for high-risk HPV positive cases, not for high-risk HPV positive cases, but in the low and intermediate, but decreasing the dose of radiotherapy, obviating the need for chemotherapy, especially the borderline N2 downstage pathologically, T3 with negative cut margins, and decreasing the radiotherapy target volume. So now what happened is, once we came to know about an increasing trend in oropharyngeal cancers, increasing HPV positivity rate, this is what happened in the Americas. Now, what we have to understand is what that I've told you about. There are 3 or 4 things that are common and remain constant. One is we need to understand that anatomical subsites are very important, whether it is HPV positive or HPV negative. And this paper of the NCDB database actually is a study of 23,000 cases, and it shows clearly that the oropharyngeal cancer subsite was very important for the patient's outcomes, and this is what you see. So if the patient did not have a tumor that was located in the tonsils, then of course the outcomes were much poorer. Now, in such a population, it may be important to use TORS as a de-escalation strategy, that you resect the early stage tumor, probably also in an infiltrative base of tongue tumor, and then do a reduced volume, reduced approach for your radiotherapy itself. Now, this is another important paper, that is the AVOID trial, which looks at this. How can you decouple the treatment of the adjuvant from decoupling it from the primary and the neck node. So what happens essentially is that your volumes for radiotherapy are becoming small. So this is a single arm phase 2 study. This is which enrolled about 60 patients. Between 2014 to 2017, patients were treated with TORS and selective neck dissection at a single institution. Patients had favorable features at the primary site, negative margins, more than 2 millimeter, no perineural invasion, no lymphovascular invasion. Required adjuvant therapy based on lymph node involvement. Surgeries were all performed at high volume centers, which means that these were expert surgeons. Patients received post-operative radiotherapy to risk areas in the involved neck and uninvolved neck. The resected primary was treated as an active avoidance structure, which means you're decoupling the treatment of the primary from the neck nodes, and concurrent chemotherapy was administered when you had extranodal extension. So if you look at the median follow-up, 2.4 years, 2-year local control 98.3%, 2-year local recurrence-free survival 97.9%, overall survival 100%, only one recurrence each at the primary and the regional site. 2 patients had distant metastasis. Median dose to the mean dose to the primary site was 36.9 gray. Sequely, only 2 patients experienced late soft tissue necrosis, which healed by conservative methods. Feeding tube dependence was 0% during RT, and also at last follow-up it was 0%. Now, this is what can be achieved. That means you leave the primary out completely. Mean dose they saw was about 39.6%. Of course, in some patients it could be even lesser than that, depending on the location and the size. And of course, you can divide the nodes into high risk as well as intermediate risk and then give the doses. And if you look at the measured doses, to the primary as well as the primary site by location, you will realize that there was some difference, but of course it was much lower, especially with protons. And this was the survival. That means by doing this kind of a decoupling approach, you could spare toxicity, reduce the dose for the primary. And if you do that, especially in tumors like the base, tongue, and tonsil, you will definitely avoid dysphagia and consequential doses to the DAR structures. So de-intensified post-operative radiotherapy that avoids the resected primary tumor site and targets only the at-risk neck after TORS for selected patients with HPV associated OPSCC may be safe. There is another similar trial called the infield trial, which has looked at all head and neck sites, and that is also quite encouraging. Now, these are the various other head and neck studies that are going on. And as Malu has clearly said, we have the ECOG 3311, we have the orators, we have the adept, the pathos, which are still to show us the results. Of course, we have some early results from the ECOG 3311. So now let's speak a little bit about the orators. This was orator 1, which included the first orator, which included both HPV positive and HPV negative patients. 68 patients were randomized. And then what they found was, of course, if you looked at the scores, finally, plus neck dissection as per HPR, primary endpoint was swallowing related quality of life. It had to be, the trial had predetermined that it had to be a 10-point difference. That did not seem to be a case. But of course, there was statistically significant difference between the radiotherapy group and TORS plus neck dissection group. And these are, of course, the scores to show the Madari scores. And then this is the graph again to show the overall survival and progression-free survival. Of course, just by virtue of being HPV positive, patients who were P16 positive did much better than the P16 negative patients. And of course, in conclusion, they said that the swallowing related quality of life scores 1 year after treatment was of course much better with radiotherapy than the radiotherapy followed by chemotherapy. This is the long-term outcomes. This also continued to remain the same, but of course the difference became smaller between the two arms, though it remains statistically different. And this again was the overall survival and the progression-free survival in the orator was. But you have to remember that the trial was not powered to definitely compare long-term quality of life outcomes and survival outcomes. Then came the orator 2. And now this was something that everybody was looking forward to, simply because again, this was something that was looking at outcomes, survival, oncologic and toxicity for TORS versus radiotherapy. And the primary endpoint was overall survival. However, unfortunately, after 61 patients were accrued, this trial had to be stopped. And why? This was because of grade 2 to 5 toxicity, 67% in the RT arm, 71% in the TORS plus neck dissection arm. And of course, quality of life were similar between the two arms. One patient in each arm required a percutaneous feeding tube. But what was written was that radiotherapy was better than TORS plus radiotherapy. And the two options, according to me, still remain equally viable. The equivocal results can be attributed to the small sample size, low volume centers, and of course, it also reveals the learning curve of TORS. But more importantly, what all of us as radiation oncologists need to understand is, instead of just being critical about TORS, the two orators actually created a lot of confusion as well as a lot of misunderstanding. My take on this was that although only T1, T2 patients were eligible, if you look at the first orator, you see that there was patients who had N2 disease, which simply meant that many more patients received trimodality treatment. Also, it talked about a 1 centimeter margin around the primary, which would be very difficult to achieve, looking at all the various parameters involved. So again, this would also in turn impair swallowing outcomes where surgery was concerned. Also, the small numbers, and especially in the orator 2, they used the NRG HN002 arm, which was 60 gray plus concurrent chemotherapy, which is a non-standard radiotherapy chemotherapy arm. And though experienced surgeons were trialists, the complications reported, that was the hemorrhage as well as the spinal problem, was actually very atypical and not so commonly encountered. Now, these are the various other trials that are ongoing. We, of course, have heard about ADEPT from Mala. Now we're looking at ECOG 3311 and the PATHOS. Now the PATHOS is something that is still ongoing, and we will have to await the results of the PATHOS trial. But we need to understand that they all consider oropharyngeal cancers that are HPV positive, and they have looked at various ways of de-intensification. In the ADEPT, they have tried to either give radiation therapy alone with different doses of cisplatinum and then or do TORS. In the other one, in ECOG, we'll just come to ECOG in more details. And in the PATHOS, you saw that lengthy diagram, which of course is very complex. So you have transoral surgery and neck dissection, followed by stratification into low, intermediate, or high risk. This is something akin to the ECOG 3311. In the low risk cases, do not have adjuvant therapy. In the intermediate risk, they're randomized to 50 to 60, again, something similar to the ECOG 3311. And in the high risk, they go on to IMRT with or without weekly cisplatinum. And therefore, it is important to watch out for the results of these trials. So let's come a little bit in detail to the ECOG 3311. So please tell me about time when I'm supposed to finish. Thank you. So we have this low risk, we have the low risk observation. Then you have high risk. Now, if you look at high risk, you have this intermediate risk where they're trying to actually dose reduce, but look carefully at the adjuvant, at the parameters that talk about adjuvant therapy. One is clear margins, or you had ECS less than or equal to 1 millimeter, that is micro ECS. Then 2 to 3 metastatic nodes, PNI or LVI. Then you do either 50 gray 25 fractions or 60 gray 30 fractions. The high risk, you will have more than 1 millimeter of ECS, more than 4 metastatic lymph nodes, and there you would give an adjuvant radiotherapy dose of 66 gray and 33 fraction plus CDDP, of course, because there is ECS in the lymph nodes. So what did they come? They came to conclusions about the intermediate risk group actually. And that is the result that we have. And in the intermediate risk group, they have seen that the 50 gray and the 60 gray group are doing equally well. Okay, so primary TORS and reduced post-operative radiotherapy result in outstanding oncologic outcome and favorable functional outcomes in the intermediate risk HPV positive oropharyngeal cancer. So which are the intermediate risk? You have less than 1 millimeter ECS, you have less than or equal to 2 positive lymph nodes, and of course cut margins may be about what you call clear margins are available. You may have PNI or LVI. So you have to remember what is their intermediate risk, because this is a little different between the various trials. So next we have a realization of better prognosis. Of course, we have a different biology, increasing role of surgery, and very possible to change indications for adjuvant therapy. Outcomes, however, have to remain uncompromised or improve quality of life. Now, having said all this, what we know so far is that the role of TORS or any form of surgery is best realized when used as single modality. can be effectively reduced. The toxicity can be effectively reduced. In advanced stage, it will be a part of combined approach, utilizing the concept of spatial cooperation. Decoupling the therapy of primary from nodes may be one way to do it, and it would allow us to further reduce toxicity without affecting outcomes. Now, having said this, let's look at the strategy first. So let's look at a few of the radiotherapy strategies which then could actually be amalgamated with these surgery techniques. So Mala did allude to this 30-gray ROC trial. So initially they started with 33 patients, they did the F-MISO, and they looked at the hypoxic and normoxic nodes. And initially in their experimentation for all these patients who were on the study, they did see to it that these patients underwent surgery to be very sure that they were doing things right. Okay. Then came this larger trial where we had 152 patients who were randomized between the various groups. Now they were not randomized. What happened was at baseline they had the F-MISO. So you had a baseline hypoxia, and at baseline if these patients did not have hypoxia. Then what did you do? 72% of these patients had baseline hypoxia. The remaining did not have. Then persistent hypoxia, again, as we said, after about 2 weeks of therapy, then these patients went on to receive 70 gray and 3 cycles of chemotherapy. That is the 100 milligram per meter square. Those who did not have hypoxia went on to receive only 30 gray and 2 cycles of chemotherapy. So you have to understand that this is something that is based on the baseline presence or absence of hypoxia. And if you look at the results, you will realize that the 2-year locoregional control for the entire group was 94.7%. 8 patients in the 30 gray cohort had nodal recurrence. 4 patients had persistent nodal disease. No nodal recurrence in the 70 gray. So this is some kind of a pointer that if you could choose some kind of a biomarker in these patients, which could be hypoxia, you could possibly reduce the dose. Now, what is important when I'm talking about my part of the study, my part of the lecture is essentially of trying to tell you all that in all these patients, they had undergone surgical debulking of the primary tumor. Whether with a positive or a negative margin, that was immaterial. And that is how they could treat the primary as well as the neck to the 30 gray. Essentially, here again, the treatment of the primary has been decoupled perhaps from the treatment of the neck. You did a surgery to begin with, then treated the primary as well as the neck, depending upon the extent of hypoxia. The next thing, of course, is we as radiation oncologists can perhaps save the dysphagia aspiration related structures, which is one of the premise for which TORS is being used. So this is something that we have to be aware of. That is the DAR study from Chris Nutting. And of course, this is actually pushing our boundaries to be able to be less toxic, less cause less damage to the dysphagia aspiration related structures. But again, here what is important is that you choose your patients correctly. Of course, do not forget brachytherapy when you're thinking of the suitable case, perhaps again as a method of dose. Dose de-escalation or volume de-escalation. And of course, this is even applicable to our HPV negative population, but for the HPV positive population, this would be a method of volume de-escalation as well as reducing the toxicity to the adjacent structures. The other thing that is very important for us today, especially volume reduction, when we have these good imaging modalities, is of course not forgetting ipsilateral irradiation in lateralized tonsillar cancers, essentially T1, T2 tumors, less than 1 centimeter extension to the soft palate and no base of tongue involvement. This is typically, and this is very effective both in the HPV negative and the HPV positive with conventional as well as with IMRT modalities. So this is something that all of us have to remember. So issues of cost is again very important when we talk about integrating treatment modalities. And from this paper from Brian O'Sullivan's group, what emerged was that if you use TORS as the only modality of treatment, you would have better quality and life adjusted years. But the moment you had to combine TORS with any other adjuvant therapy, then its efficiency as a method to reduce costs will fall. So that's why it is very important for us to be able to integrate the right therapy with the right patient in the right way. So cost effectiveness of TORS is unlikely to be realized if used in an unselected fashion. So in conclusion, I'd like to say in the HPV associated OPSCC, the biology is favorable. There's no doubt about that. Most patients in the low and intermediate risk will do better than the negative counterparts. Again, there is no debate about this. The onus is on toxicity reduction without compromised outcomes. TORS is a fascinating tool that is useful in the modern management of well-selected HPV positive OPSCC. Patient selection is the key to the useful application of this modality, and further research is necessary to clarify the inductions for and delivery of adjuvant therapy following TORS. Use of TORS in unselected patients who are likely to require adjuvant radiotherapy is unlikely to be cost effective, as I've already said. And the financial value of TORS must be clarified in future studies to ensure its longevity and continued application. Use of discretion in the use of TORS and to identify the patient who is most likely to benefit in order to solidify this useful modality in the oncologic paradigms of the future. Now, these are things that I've taken from a particular paper by David Sure, and the future offers exciting opportunities to combine TORS and radiotherapy in unique ways. So it is up to us to be able to utilize TORS in the most effective way and not just discard it as a useless tool. It can be used, but we have to select the right patient for the right modality of treatment, and its best application is for those patients who may not require any further therapy other than surgery. This is the end. Thank you very much. And I'd like to invite all of you, after attending the Arroy Eastro course, to come to Mumbai for FHNO 2024. Thank you very much for this kind invitation and patient hearing.
It was such a wonderful talk, madam. Such a power-packed talk, actually. Madam, how many of your patients would have a TORS treatment? Have you started off?
Yeah, so you know what happened is Tata Hospital actually has initiated a clinical trial. For want of time, I've not shown the scope trial. If you remember, we had invited you to participate also.
Yes.
We wanted it to do it only in HPV negative tumors because that was our problem. But despite saying that, despite having almost about, you know, if you look at our head and neck cases, almost about 25% of them are oropharyngeal cancers. Despite that, we get very few patients who are actually suitable for TORS excision. Because, you know, again, if you see Surendra Dabas's paper, and there's another paper which actually looks at what is our common cancer, it's either soft palate or it is base of tongue. So here comes the problem of, you know, lateral extension of the tumor and muscular involvement. So there, if the surgeon cannot achieve negative margins, then it is of no use doing TORS for these patients. So that's, and we tried not to do anything that will actually intensify. Then we would rather do concurrent chemoradiotherapy and then do adjuvant therapy. So that's how we really, the trial has not, though we are striving hard to accrue, and everybody thinks it's an important trial, it's becoming very difficult to accrue patients on the trial.
Patient selection seems to be the most important thing in TORS.
Ma'am, there's a question for you in the chat box. Ma'am, how was hypoxia identified in the study? And any tumor more than 2 centimeter approximately usually has a hypoxic center. So are all those patients given 70 gray?
No, so actually, if you know, it is very important for you to actually read the ROC trial, the 30 gray ROC trial. Now, they are very, very careful about how they've selected the patients. So if you look at it, F-MISO is a very difficult tracer to interpret in your pictures. So they have actually practiced and then learned to recognize the hypoxic areas in the tumor, because F-MISO is not as distinct and as clear as FDG PET. So in patients who had F-MISO uptake at baseline, whatever it was, were considered as hypoxic tumors. 1 week into the radiotherapy, they again repeated the F-MISO uptake. There, if there was complete disappearance, that means the signal to background ratio was as they had practiced, then that patient was considered as being normoxic. And then that patient went on to receive only 30 gray. They did not use size criteria. They have only used the F-MISO uptake. And initially, when they did their 19-patient study, they have also looked at FDG PET because that shows a more distinct kind of difference from the background. Whereas F-MISO is more difficult, but it is a better tracer for hypoxia. So they've not used size as the cutoff. They've used just the uptake in the tumor to look at whether there was hypoxia or no hypoxia. So I would suggest that all of you do read this paper to understand the intricacies of, it seems a very brave paper if you ask me, to do only 30 gray, we've never heard of this, right? But because it was HPV positive, they could do it. Biologically, they were different tumors, and all patients, mind you, had undergone surgical debulking of their primary tumor.
Thank you very much. Thank you very much for this beautiful session, ma'am. We are very glad to have you here.
Thank you. Thank you very much. My pleasure.
The next session is on nodal volume delineation in carcinoma oropharynx. I invite Dr. Lekha M. Nair, Assistant Professor, Department of Radiation Oncology, RCC Thiruvananthapuram, for the session. Over to you, ma'am.
Thank you, Livia, for the introduction. Am I audible?
Yes, ma'am.
Can you see my slides?
Oh, yes, ma'am. Slides are visible.
Thank you, Bhagya. Now, my topic is nodal volume delineation in carcinoma oropharynx. As you all know, the main subsites of oropharynx include tonsil, base of tongue and varicula, soft palate, and pharyngeal wall, the posterior or the lateral pharyngeal wall. So, what is the specialty of HPV positive carcinoma oropharynx? They usually have a small primary with a big cystic node. Even though the node is very large and cystic, the chance of extracapsular spread is very less. They usually have well-defined borders and are less infiltrative in nature. So, which are the common lymph nodes involved in carcinoma oropharynx? Oropharynx has rich lymphatic drainage. The most common level involved is level 2, followed by level 3 and 4A. The posterior pharyngeal wall tumors can primarily drain to retropharyngeal nodes. And if there are multiple level 2, 3 or 4 nodes, there could be a level 5 involvement as well. And when the primary tumor extends into oral cavity, 1B node also can be involved. How to identify positive nodes in a cross-sectional imaging? First one is the size criteria. The node with short axis diameter more than 10 millimeter is considered radiologically significant. Exception is retropharyngeal node, where 5 to 8 millimeter is considered significant. Here, this node is more than 1 centimeter. This is a significant node, whereas you can see a small node here. According to the size criteria, this might not be a significant node. The next thing is central necrosis. Here, you can see a necrotic center here. In this large node also, you can see heterogeneously necrotic areas. Then the shape. The malignant nodes are round in shape as compared to oval nodes. Then the next sign is the loss of fatty hilum, and the most important sign is the presence of extracapsular spread. Is the definitive sign of malignancy. You can see a node infiltrating the sternocleidomastoid and the paraspinal muscles. And presence of cluster of 3 or more lymph nodes between 6 and 8 mm is also considered significant. About the laterality of lymphatic drainage. As you know, oropharynx has rich lymphatics, and usually it has bilateral drainage, especially the soft palate, base of tongue, and the pharyngeal wall. And an exception to this is tonsil, which has mainly unilateral drainage. So, ipsilateral neck treatment can be considered in well lateralized T1, T2 N0 tonsillar lesions without extension, mucosal extension to base of tongue, soft palate, or tonsillar pillars. These are the guidelines for nodal volume delineation for oropharynx. This is the neck node delineation, guidelines for delineation of neck node levels. And you should understand that there is no difference in contouring for HPV positive and HPV negative tumors. All these guidelines are based on when can be applied when the patient is in supine position with the neck in neutral position. And coming to the first case, this is a T1, this is a T2 N0 tonsil. This is the GTV. Here, the patient was given ipsilateral treatment. Ipsilateral level 2, 3, and 4A was treated in the lower CTV. And there is a 50 gray equivalent dose, and no contralateral treatment was given for this patient. This is a T2 N0 soft palate. It is going into the base of tongue. And this is not negative. So there is no higher CTV node. And the lower CTV node includes bilateral level 2, 3, and 4A. This is the topogram, the coronal and the sagittal view. Then coming to the borders of level 2. So the level 2 starts at the caudal edge of the lateral process of C1, and it is a superior border. And the lower border is at the lower border of the hyoid bone. This is the lowermost cut and this is the uppermost cut. Then about the anterior. Anteriorly, it is bordered by the posterior border of the submandibular gland. Posteriorly, it is the posterior border of the sternocleidomastoid. Medially, by the internal carotid artery and the scalenus muscles. Laterally, it is bounded by the medial edge of the sternocleidomastoid or the posterior belly of the digastric. Coming to level 3 extends from the lower border of the hyoid bone to the lower border of the cricoid cartilage. This is from lower border of hyoid bone to lower border of cricoid cartilage. Anterior extent is the anterior edge of the sternocleidomastoid or posterior 1/3 of the thyrohyoid muscle. Posteriorly, it is the posterior border of the sternocleidomastoid. Medially, it is the common carotid artery and the scalenus muscle. Laterally, it is the medial edge of the sternocleidomastoid muscle. Coming to level 4A, 4A extends from the lower border of the cricoid cartilage to 2 cm above the manubrium sternum. This is the uppermost cut. It is where the lower border of the cricoid cartilage, and this is the lowermost cut at 2 cm above the manubrium sternum. Anterior border is the anterior edge of the sternocleidomastoid. Posteriorly, it is the posterior edge of the sternocleidomastoid. Medially, it is the medial edge of the common carotid artery, the thyroid, the medial lateral border of the thyroid gland, the scalene muscles. Lateral border is the medial edge of the sternocleidomastoid. Coming to another coming to node positive carcinoma oropharynx. For node positive cases, we have to delineate the GTV node accurately. For that, we need information from clinical examination. Clinical examination is very important, as like in delineation of GTV primary. We have to examine the levels of nodal involvement, and we have to look for the signs of extranodal extension, and extranodal extension in the form of skin involvement. Subtle skin involvement can be missed on cross-sectional imaging. It is better identified in clinical examination. Then we have to clear information from the diagnostic imaging. And of course, we contour the GTV node in a planning CT scan with contrast with 2 to 3 mm thick slices. So this is a N1 node. So we have a GTV node here. Then the high-risk CTV is delineated by giving an isotropic margin of 5 mm to the GTV node. This is the high-risk CTV, this is CTV1. Then comes the intermediate risk CTV. The entire nodal level with positive nodes will be included in the intermediate risk CTV. So we have a level 2 node here. So the entire level 2 will be included in the intermediate risk CTV, and this nodal level will be treated to 60 gray equivalent dose. Then about the lower CTV, this is the intermediate risk CTV. That is the entire level 2 will be treated in the intermediate risk volume. And about the lower nodal CTV, the uninvolved nodal levels will be included in the lower CTV. That is the ipsilateral level 3 and 4A and contralateral level 2, 3 and 4A are included in the lower CTV, and this volume will be treated to 50 gray equivalent dose. Coming to N2 node, here we have bilateral nodes, and we have to delineate the GTV node, and high-risk CTV node is delineated by giving a 5 mm isotropic expansion to the GTV node. As I said earlier, the intermediate risk CTV includes the entire nodal level with positive nodes. So here we have nodes in level 2 and level 3 bilaterally. So the intermediate CTV includes the entire level 2 and 3 bilateral by level 2 and 3. So coming to the lower CTV, if there are multiple positive nodes or contralateral bilateral nodes, then you have to include some areas in the lower CTV. This includes the level 5A and B, the retrostyloid, the retropharyngeal. So this is the oleum, like this is the retrostyloid nodes. These are the posterior level 5A and 5B nodes, and these are the level 4A nodes. Level 4A, bilateral level 4A, and this is the level 5A and B. So this blue color depicts the high risk CTV node. This cyan color is the intermediate risk CTV node, and the red color is the low risk CTV node. Coming to entry node. So we have a fairly big node here with extracapsular extension. So we can see the nodal GTV here. It involves the level 2, 3, and the 4 regions. So the high risk CTV here is drawn by giving a 1 centimeter isotropic expansion from the visible edge of the node. Because of the extracapsular extension, we have given a margin of 1 centimeter instead of the 5 millimeter. So this is the high risk GTV, high risk CTV node. This is the high risk CTV by giving a 1 centimeter isotropic expansion. And the intermediate risk CTV includes the entire nodal level with the positive nodes. So we have positive nodes in level 2, 3, and 4. So the entire level 2, 3, and 4 are involved in the intermediate risk CTV. About the lower CTV, we have the ipsilateral and contralateral uninvolved nodes. So the ipsilateral, this is the ipsilateral retrostylo, the ipsilateral 1B, ipsilateral 5A and 5B, and the contralateral level 2, 3, and 4A are included in the lower CTV. So when to treat level 5 nodes? Of course, if you have positive nodes in level 5, you have to include it in the high risk CTV node. If there are multiple node positive in case of N2 and N3 nodes, guidelines says to include ipsilateral level 5 in the lower CTV. So what are the boundaries of level 5? Level 5, the cranial border is the cranial edge of the body of hyoid bone, and caudal limit is the plane just below the transcervical vessels. Anterior limit is the posterior edge of the sternocleidomastoid. Posteriorly, it is the anterior border of the trapezius muscle. Medially, it is the levator scapulae and the scalene muscles, and laterally, it is bounded by the platysma or the skin. When to include retrostyloid nodes in lower CTV? When you have multiple positive level 2 nodes, or when there is bulky infiltration of upper level 2 with extracapsular spread, then you have to include retrostyloid or 7B nodes in the lower CTV. So the retrostyloid node starts at the base of the skull, and it continues at the level 2. So the lower limit is the caudal edge of the lateral process of C1. The anterior boundary is the pre-styloid parapharyngeal space. The posterior boundary is the base of skull and C1 vertebra. Laterally, it is the styloid process and the deep lobe of parotid, medially by the medial border of the internal carotid artery. What are the indications for treating 1B? When you have clinically significant nodes in 1B region, then it should be included in the high risk CTA by giving a 5 millimeter expansion to the GTV node. And there are certain indications for including 1B in the lower CTV. For example, when there is extension to oral cavity, say when there is a soft palate lesion extending to hard palate, or when there is a tonsillar lesion extending to RMT, or when there is a base of tongue lesion extending to oral tongue, then you have to treat 1B in the low risk volume. And also when there are bulky nodes or extracapsular spread, especially anterior extracapsular spread in level 2A, then also you have to include 1B in the low risk CTV. And about the boundaries of 1B, 1B starts the cranial edge of the cranial border of the submandibular gland of the mylohyoid muscle. The caudal limit is the caudal edge of the submandibular gland of the body of hyoid or the mandible. Then anteriorly it is the symphysis menti, and posteriorly it is the posterior border of the submandibular gland. Medial border is the lateral border of the digastric, anterior belly of the digastric, and lateral border is the inner side of the inner edge of the mandible. When to treat retropharyngeal nodes? Always remember, posterior pharyngeal wall tumors drain primarily to retropharyngeal nodes. So even if it is N0, you have to treat bilateral retropharyngeal nodes in the lower CTV. And for in case of N2 and N3 tumors, should we treat retropharyngeal nodes for all N2, 3 tumors? This guideline says yes, but it is a matter of debate. We do not routinely treat all ipsilateral retropharyngeal nodes for all N2, 3 tumors. About the boundaries of the retropharyngeal node, it starts at the upper cranial edge of the C1 vertebra, and it ends at the cranial edge of the hyoid bone. Then anteriorly, it is bounded by the superior and middle in middle constrictor muscles. Posteriorly, it is the prevertebral muscles, the longest capitis and the longest scoli. And laterally, it is the medial border of the internal carotid artery, and medially, by the line parallel to the lateral edge of the longest capitis muscle. So the different dose levels for nodal CTV. The higher CTV is delineated by giving a 5 millimeter isotropic margin to the GTV node, and in case of nodes with extracapsular spread, a 1 centimeter isotropic margin is given from the visible edge of the node. And this area should be treated to 70 gray equivalent dose. And intermediate CTV includes the entire nodal level with positive nodes, and this area should be treated to 60 gray equivalent dose. And the uninvolved nodal levels with more than 10 to 15% of occult lymph node metastasis should be included in the lower CTV, and this volume should be treated to 50 gray equivalent dose. Some centers use only 2 dose levels, that is higher CTV and the lower CTV, and they include the entire nodal level with positive nodes in the high risk volume, that is 70 gray equivalent dose. And the lower CTV covers the uninvolved nodal levels, and that will be treated to 50 gray equivalent. And we routinely treat with 3 dose levels: high risk, the intermediate risk, and the low risk CTV. Then another area of concern is the delineation of nodal CTV after neoadjuvant chemotherapy. There is no doubt you have to delineate CTV node by giving 5 millimeter margin to the pre-chemo GTV. For that, co-registration with the pre-chemo imaging would be useful for that. So in nutshell, the high risk CTV is drawn by giving a 5 millimeter margin to the gross node, GTV node. The intermediate risk CTV is treated, the nodal levels, the entire nodal level with positive nodes will be covered in the intermediate risk CTV and will be treated to 60 gray equivalent dose. And the lower CTV for all tumors except T1, T2, and 0 well lateralized tonsillar tumors. For all other tumors, you have to treat bilateral level 2, 3, and 4. Invariably, you have to treat these bilateral nodes. And you have to treat some other extra areas in case of N2 and N3. This includes ipsilateral 5A, 5B, then the retrostyloid and the retropharyngeal nodes in case of multiple node positive or N3 nodes. And you should include 1B in the lower CTV if there is extracapsular spread, anterior extracapsular spread at level 2, or when the primary tumor extends into oral cavity. And for posterior pharyngeal wall tumors, you have to include bilateral retropharyngeal nodes in the lower scolium. Thank you.
Thank you, madam, for this wonderful session, educative session on the intricacies of nodal volume delineation. We don't see any questions in the chat box. Let us move on to the final session for today by Dr. Sajju Bhasi. He's an additional professor, Department of Radiation Physics, RCC Trivandrum, and the topic is how to generate a high-quality VMAT plan for carcinoma oropharynx. So please.
Yeah, let me share the screen.
Can you stop screen sharing?
Lega, can you stop your screen? Okay, I think I can. Sorry, just a minute. Something is going wrong. Sorry.
Left hand.
Can you see my screen?
No, sir, it is
No,
not
sir.
visible.
Just a minute.
Sir, can you minimize the presentation to the desktop?
Yeah, I
The la-
minimized it. I minimized it.
Yeah.
I'll just open that once more, please.
Sure, sir.
Huawei.
In the meantime, Lekha ma'am, if you're still with us, there's a question for you.
And like he's here. Yeah, please ask.
Yes.
Ma'am, the question is, will you superimpose nodal images even when you have near total resolution after NACT?
We have to delineate nodal GTV, right? When there is near total resolution, there is no GTV post chemo. So you have to seek the help of pre-chemo imaging. So superimposition will not be accurate because of the neck position, but you have to superimpose the area of interest so that you can delineate it correctly.
Thank you very much, ma'am. Madam, there's one more question. If the disease is crossing midline, do you treat the contralateral first echelon nodes to intermediate risk volume?
No, if the nodes are not involved, then that area will be treated in the low risk CTV only. We are giving prophylactic dose, right? That will be enough.
Thank you very much, ma'am. I think that's all for the questions. Over to you, Sir Joseph.
Sir, can you unmute?
Yes. Can you hear me now?
Perfect.
Yes,
Yeah,
sir.
sorry about all those technical things. Okay. Usually I clear out all the technical faults, then I end up with a technical fault. Okay, now that the contours are ready, we need to generate a plan for our contour. So always the issue is what should we be planning for? So we have different techniques that are that we can use for our generating a plan. So as far as 3D CRT is concerned, it's no longer considered as a standard practice, mainly because of the low sparing it gives to the critical organ. But the advantage over there is that, like, you never miss the target. But at the same time, you never miss the normal tissues or the normal organs as well. So there is no sparing as such. Then came the intensity modulated technique, wherein you can modulate the beam to the shape of your targets. So that brought in the advantage of sparing most of your critical structures. Then what is the main difference between the static intensity modulated therapy and the volumetric? So the main disadvantage which the static intensity modulated therapy had was mainly on the time constraint. Like, the patient has to be on the table for a longer time. So an alternative method was the volumetric modulated arc therapy, wherein we could finish off the treatment in 2 or 3 minutes. So with that advantage, the thing which we were all looking for was how we can finish off the treatment at the earliest, because that brought in more advantage of in terms of less uncertainty when the patient is on the table for a longer time. So now that what should be our target that we should be looking for? So whenever I get a contour ready for planning, so each contour will be a new challenge for me. And it brings in the PTVs of either the primary and the node, then the intermediate risk oleum and the low risk oleum. So each oleum from each patient will be of different shapes, and it brings in a challenge for the generating a new plan. So if you have a condo with only the targets, that's the easiest way to generate a plan. But always the limitation brought in by the critical organs or the tissues that need to be spared. So as far as head and neck is concerned, we know that spinal cord, brainstem, and optic structures are all serial structures, and they need to be respected in all the plans. So even if you generate a plan which has a complete coverage of your targets, and one of the structures is the tolerance is not met, then there is no point in, or there is no, that plan is not an acceptable one. Similarly, the other constraints for the brain, the constrictors, larynx, oral cavity. So all of them has to be respected, and they need to be maintained to the tolerance level. Then only we can say that, okay, this plan is ready for treatment. So other than the structures that have been marked and given to you, there are the normal tissue that is outside the contour areas. Those are called the non-specific normal tissue. So we should always have an eye on what is the dose that these normal tissues also receive, and should also consider reducing dose to those normal tissues. Now, these are the contours that we get. Like, for example, we have a 66 gray oleum, then we have the 60 gray oleum and the 54 gray oleum. So what about the 66 gray oleum? If you look at the 66 gray oleum, the main challenge over there is the critical organs which are lying close to them. And you can see that when in this particular case, when we have the 66 gray oleum, there is a air pocket or the air cavity which is close to the 66 gray oleum. So that always brings in a challenge to have a decent dose to this 66 gray oleum. So then comes the other challenge of the critical organs. So as far as oropharynx is concerned, it will not extend more towards the optical structure, so as in nasopharynx. But here we should look at constrictors, because that nowadays we get constrictors contoured in different levels, the superior, middle, and the inferior constrictors. So we should try to achieve a dose, a decent dose, as low as reasonably achievable, I'll say, because we don't have a specific dose value as such to target for the constrictors, because many a times we see that the constrictors will be overlapped with the target oleum. So in those scenarios, we cannot say that, okay, the mean oleum receiving mean volume outside the PTV to receive a certain dose. So we always try to reduce the dose to as low as reasonably achievable. Why I say reasonably achievable is because we don't want to underdose the targets in the name of saving the critical structures, or in this case, the constrictors. So how do I prioritize how do I apply my priority when I do the optimization? So I give equal priority to my PTVs and to my critical organs. So especially the spinal cord and the brainstem. So because even if I have a good coverage and I don't get the constraints well within the level for spinal cord and brainstem, then that's not an acceptable plan. In the other way around, like if I can spare the critical organs and I don't have a coverage, then that again is not an acceptable plan. Then coming to the constrictors, again, as I said, we should respect the constrictors to the level which we can achieve. I mean, earlier we used to have the constrictors as a single structure, but these days we get it as split structures. Then, as I said, again, the non-specific tissues. Now, if we look at the coverage, the dose coverage, here, as I said, like when we have the parotids very close to the 66 grade or the high risk oleum, you hardly will be able to achieve the parotid dose constraints. Similarly, you can see over here the constrictors also overlapping to the target oleum. So in those scenarios, what I usually do is I see that those volumes doesn't get 105% dose. So I try to limit the maximum dose away from those critical structures, either the parotids or the overlapping oral cavity or the constrictors. So I try to take out the hotspots out from the those structures. Now, these are the critical organ doses that we keep in mind when we do the planning. And as I said, it could be either the point dose or it could be the mean doses as in the structures demand. Now, how can you say that a plan is a good plan? So my understanding is if you want to have a good plan, you need to spend 5 minutes with your physician. So before you generate a plan, when the contours are with you, you have a discussion with your physician, spend 5 minutes discussing on what is that they are looking for. It's not that we just be looking for the benchmark points and saying that, okay, I have achieved the benchmarks, okay, this is going to be a good plan. No. So the clinician will have certain things in mind when they give us a contour and expects a certain type of coverage. So a 5 minute discussion will definitely help you to bring in a good plan. Then, as I said, okay, look at the target structures and look at what is the prescription that has to be given and try to achieve those prescriptions covering the targets. The normal tissue constraints, definitely they need to be met. And the maximum dose. So if you end up with having a maximum dose inside the target oleum and the doctor says that, oh, he's not having that happy face, then you can go back and mark those hotspots or the maximum dose. I cannot call it as a hotspot because it is within the target. So I go back and mark those high dose areas and try to do a re-optimization. So in our center, we do optimization n number of times. We are never lazy enough to say that, okay, this is the maximum I can do. So we do optimization till there is a happy face on my oncologist's face. Dose spillage. So that dose spillage to the normal tissue, as I said, dose spillage to the normal tissue is one thing that you should be careful about or you should always address to, because you don't want those unnecessarily spilling on inside your oral cavity or to the back of your head. So all those undesired dose spillages also has to be addressed. And the main thing that we should keep in mind when you generate a plan is to minimize the plan complexity. So what do you mean by plan complexity? So you can generate a plan with minimum monitor units, or you can increase the complexity of the plan to deliver the same dose, but with a large monitor unit. What does it mean is, like, for example, you have a structure contoured close to the skin. maybe by mistake you forgot to crop it, and you try to achieve a dose distribution to that. So that gives a task to the system to somehow deposit dose near to the skin. So usually what we do is we try to we crop those structures unless there is a skin involvement wherein we always go for the bolus. Otherwise, we should always try to reduce or keep the targets away from the skin. Another scenario is like when you try to optimize for a target or for a dose which will be unreasonable. For example, like you say that, okay, my spinal cord should receive 0 dose. So that is a unreasonable task that you're giving to your planning system. So all those will bring a complexity to your plan. So what happens when there is a complexity to the plan? So there will be more, those plans will be more prone to executional errors. So try to have a plan with minimum complexity. So once you have all these in place, then you'll have a good plan which your oncologist will be happy to accept. Thank you.
Thank you, sir. Thank you, sir, for this detailed session on all these generating volumes and with VMAT for CE oropharynx. I invite Dr. Cecil to conclude this session. Sir, please.
In the meantime, please check for any questions for Saju sir also. Okay, I sincerely thank all the for the program. So I sincerely thank Francis sir for the great support, Rajini sir for the guidance, all the speakers, especially we had Sarbani madam. Thank you, madam, for sparing time. Madam joined at 4:50. So and madam is still now online. Thank you very much for that. I have noticed that in all the meetings, madam joined from the time from the beginning of the program till the end. Okay. Thank you very much. I sincerely thank Priya for giving a very good lecture on the radiology part, Saju sir on the physics part, and I sincerely thank all my colleagues, Malu and Lekha. I sincerely thank again Rajini sir for giving the guidance and this opportunity, all the delegates. And I will share to all the registered. We had almost 517 registered online delegates were there. So I will send all the delegates the link for the YouTube channel, and also I will seek permission from all the faculty. Then if they give the permission, I will share the slides also. Thank you very much for the great opportunity. Thank you again. Good night.
Thank you, Cecil, Rajneesh, and the entire RCC team. Thank you very much.
Thank you. Thank you. Thank you.
Good night.
Thanks, Cecil.
Bye.
Good night.